Very good morning to all doctors who are present, and we shall start now the session. So, strictly 6 minutes time will be permitted, and after that the AV will go by itself. So, stick on your time, and all the best. And may I know your name?
Dr. Gandhi Priyanshi.
You will be presenting first? Okay. So, Dr. Gandhi will be presenting first.
Hello. Good morning everyone. My name is Dr. Priyanshi Gandhi, and today my topic is effect of duration and management of rheumatoid arthritis on prevalence of dry eye syndrome in southern Rajasthan. Talking about the dry eye, it is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiologic roles. Rheumatoid arthritis is a systemic autoimmune disease characterized by inflammatory arthritis and extra-articular involvement. Although considered a joint disease, rheumatoid arthritis is associated with the involvement of extra-articular manifestations. Ocular manifestations involved with RA are keratoconjunctivitis sicca, episcleritis, scleritis, corneal changes, and retinal vasculitis. To evaluate RA disease activity in dry eye, it is of clinical importance for early detection. Then comes the aims and objectives. To study the prevalence of dry eye syndrome, to know the effect of RA disease activity and the effect of RA treatment on dry eye syndrome. This study was carried out in Outpatient Department of Ophthalmology in American International Institute of Medical Sciences, Udaipur. The duration of this study was from March 2023 to August 2023. It is a prospective observational study, and according to the previous medical records, 50 patients were enrolled for the study. The study, the inclusion criteria were, it was according to the American Rheumatology 2020 criteria, and the patient excluded were patient having any recent eye surgery or any disease pre-existing to the dryness of the eyes, or there is any joint pain despite of RA. Consent was taken from the patients, all the required tests were performed, and results were noted without disclosing their identity. All the selected patients were evaluated on the basis of Schirmer's test and corneal fluorescein staining. Based on Schirmer's test, the interpretation were, if it is less than 5 mm, it is considered severe, 5 to 10 mm moderate, 10 to 15 mm mild, and more than 15 mm considered normal tear production. Then comes the corneal fluorescein staining. The slit lamp microscope is employed in this inspection. A fluorescent paper is moistened with normal saline or topical anesthesia and subjected at the lower fornix of the patient. Patient is asked to close and open eyes for the proper distribution of the tear film. The presence or absence of superficial punctate keratitis was observed under the cobalt blue light. Talking about the results, in this study, 50 patients were enrolled, out of which 90% were females and 10% were males. Talking about the prevalence of dry eye, according to Schirmer's test without anesthesia, it was 54%, and Schirmer's with anesthesia, it was 82%. Then comes the correlation of duration of RA with Schirmer's test and corneal staining. According to duration, RA patients were divided into two groups, those who had history of RA of less than 5 years and those who were suffering from RA 5 years or more. There were 29 patients out of 50 who had RA for less than 5 years, and 21 patients were belonging to the second group with history of RA of 5 years or more. Out of 29 patients, 48.8% according to Schirmer's without anesthesia and 79.3% patients according to Schirmer's with anesthesia were found to have dry eyes. From 21 patients, 61.9% according to Schirmer's without anesthesia and 85.7% patients as per Schirmer's with anesthesia were diagnosed with dry eyes. Coming to corneal staining, out of 50, 48% patients were observed to have SPKs on corneal staining, and they were equally divided in both the groups of duration of RA. Then comes the correlation of treatment of RA with Schirmer's test and corneal staining. Amongst 50, 42 patients were on treatment and 8 patients did not take any treatment for RA. Out of 42, 52.4% according to Schirmer's without anesthesia and 83.3% patients according to Schirmer's with anesthesia were having dry eyes. Out of 8, 62.5% on basis of Schirmer's without anesthesia and 75% patients on basis of Schirmer's with anesthesia were found to have dry eyes. The corneal staining was positive in 50% patients out of 42 who were on treatment and 37.5% patients out of 8 who were not on any treatment. Coming to the discussion, RA is a chronic inflammatory disease with extraarticular involvement. The correlation between dry eye and RA disease showed controversy in previous studies. There is a study, Nashwa M. Abdul Allah et al. Enrolled 42 RA patients, out of which 30 were having dry eyes. The severity of dryness measured by Schirmer test, TBUT, and OSS didn't show significant correlation with RA activity, but the duration of RA had statistical significance in correlation with Schirmer's test and OSS. Then comes the in present study, 54% patients with RA were having dry eye syndrome based on Schirmer's test, with increase to 82% on Schirmer's test with anesthesia. From patients with RA for more than 5 years, 61.9% were having dry eyes, and those who were not on treatment, 62.5% were having diagnosed with dry eye. We observed that in groups with longer duration of disease and who were not taking treatment for RA had higher number of patients having dry eyes clinically, although we couldn't find any statistical significance. To conclude this, RA patients are prone for dry eyes irrespective of symptoms of dryness and duration of treatment of RA. Dry eye cannot be excluded even in patients with only mild RA, hence patients should be always examined for dryness regardless of RA activity. Thank you.
In your study, you compared with you were just trying to prove a point of patients having dry eyes or not, but were you also looking for the grade of disease of dryness in the as per the severity of rheumatoid arthritis?
Sir, in my
symptomatically.
Yes, sir. Sir, in my study, I tried to find out the prevalence of dryness in RA patients and also the effect of duration of the treatment and the management of RA on the dry eye, not the severity part.
Thank you, Dr. Gandhi. Kindly collect your certificate. Well presented. So the next speaker, Dr. Aneli is present.
Like any one of you can come and present because there are a lot of speakers and I think most of them have not yet come. So anyone who is ready can come, please.
What's your name?
Dr. Amit. Dr. Amit.
Okay, come.
Dr. Amita Agarwal.
Amrit Sidhu? Okay, right. Kindly stick to your time.
Good morning, everyone. I, Dr. Amit, am here to present a rare case of Graves' eye disease with ocular myasthenia gravis in a pediatric patient. Introduction. Graves' disease is an autoimmune disease in which the antibodies are formed against thyroid receptors. Ophthalmopathy is the most common extrathyroidal manifestation of Graves' disease, characterized by inflammation of extraocular muscles, interstitial tissue, or orbital fat. Myasthenia gravis is an autoimmune disease that affects the NMJ, resulting in classical symptoms of variable muscle weakness and fatiguability. Ocular myasthenia is a subtype of myasthenia gravis that specifically involves the extraocular muscle, levator, palpebral superioris, or orbicularis oculi muscle. When myasthenia presents before the age of 19 years, then it is termed as juvenile myasthenia gravis. Myasthenia gravis and Graves' eye disease have known to coexist in adults, but very few such cases have reported in pediatric age group. Here we present one such rare case where a 16-year-old girl, a known case of Graves' disease, presented to the IOPD with features of ocular myasthenia. Case history. Chief complaints: a 16-year-old female presented to the IOPD with the chief complaints of drooping of left upper eyelid since 6 months, which worsens as the day progresses and relieves with rest. She also complained of double vision and outward deviation of left eye since 2 months. Past history: the patient has been diagnosed with Graves' disease elsewhere 2 years back and is taking medication for the same. She also gave a history of protrusion of both eyes since 6 months, which reduced slightly over time with the current medication. Medical history, she is on carbamazole tablet and tablet prednisolone. No significant systemic or family history is present, except the fact that she also complained of difficulty in swallowing since 2 months. Coming to the ocular examination, the pupil in the both eyes were round, regular, and reactive. The vision in the right eye was 6 by 6 part, on pinhole 6 by 6, left eye 6 by 12, on pinhole 6 by 6 part. IOPs were normal. Extraocular movements in the left eye were variable. There was a variable restriction in elevation, dextro elevation, adduction, dextro depression, and depression. Also, the left eye showed 30-degree exotropia on Hirschberg's test. Ptosis evaluation. The lid gaze was normally present in both the eyes. The palpebral fissure height was 4 millimeters in the left eye, MRD1 minus 2 millimeters, MRD2 6 millimeters. LPS action was fair in the left eye. Jaw winking was absent and Bell's phenomena present in both the eyes. Exophthalmometry. Measured about 20 millimeters in the right eye, and in the left eye it was 24 millimeters. Then intermittent diplopia was present and fundus was normal in both the eyes. Now, based on this ocular examination, we have 3 prominent signs: restricted extraocular movements, ptosis, exophthalmos. Provisional diagnosis we make is Graves' disease with ocular myasthenia gravis or third nerve palsy with pupillary sparring. We conducted ice pack test, which was turned out to be positive, as ice was applied for several minutes on the left eye, and we observed an improvement of 2 millimeters in the ptotic lid. It's a highly sensitive and specific test. Other tests that were conducted that suggested of myasthenia gravis were: the one, diurnal variation was present in the doses that worsens as the day progresses and improves with rest. There was positive sleep test, positive lid fatigability, positive Cogan lid twitch, ice pack, neostigmine methyl sulfate test, and RNS was done that showed more than 10% incremental response. Serology suggested raised T3, T4, reduced TSH, and it was positive for anti-TPO and TRAB antibodies suggesting Graves' disease. Ultrasonography of the neck revealed that thyroiditis changes were present bilaterally, and MRI scan of the brain and orbit showed no significant abnormality. Treatment. On the basis of examination, we diagnosed it to be a case of ocular myasthenia gravis. The patient is advised to continue with carbamazole and prednisolone along with vitamin D. For myasthenia gravis, we have added acetylcholine esterase inhibitor tablet pyridostigmine 60 milligrams TDS, and it remains the first-line drug to improve the symptoms. The topical lubricant and fog glasses have been advised for the left eye, advised for temporary relief, and the patient is kept in regular follow-up. Discussion. Ocular myasthenia gravis is the great masquerade owing to the varied clinical presentation. It sometimes mimic isolated cranial nerve palsies, since about 90% of the myasthenia patients present with extraocular muscle weakness and droopy eyelids and double vision. Extraocular muscles are most commonly affected because the twitch fibers are more susceptible to fatigue, and the tonic fibers necessary to sustain gaze has fewer acetylcholine receptors. Several hypotheses have been put forward to explain the association of thyroid eye disease with ocular myasthenia gravis, one of them being the presence of thyrotropin receptor on arbutal fibroblast. Juvenile myasthenia is a rare disorder that is acquired in the childhood. It represents 10 to 15% of all the cases of myasthenia. Children presenting with purely ocular myasthenia gravis may later on develop generalized myasthenia within a span of 2 years. Myasthenia is a systemic disease with a potential, which can be potentially fatal. Therefore, managing a patient in cooperation with neurologist is advisable. Thank you.
It's nice case, a combination of two disease entity. I just want to suggest whenever you are describing your school findings, you can put a 9-case CP, 9-case picture of your movements.
Okay.
That is nice to see.
Thank you.
Kindly collect your certificate. Right, okay. So Dr. Amita will be presenting. Right, okay. All the best.
Good morning, everyone. Today I am going to present my paper on orbital mucormycosis, tackling the black fungus. Mucormycosis is a rare opportunistic fungal infection commonly affecting immunocompromised individuals. There was a surge in the number of these cases during the second wave of the coronavirus disease 2019 in India within a week or few weeks post-recovery. The most common clinical manifestation of mucormycosis is rhino-orbital cerebral mucormycosis, ROCM. This infection is characterized by tissue necrosis, which appears as a black eschar or discharge in the nasal or oral cavity, hence the name black fungus. The non-specific symptoms of the disease may cause a delay in diagnosis, and rapid progression is responsible for the high mortality rate of 40 to 80%. Hence, early diagnosis is essential to reduce morbidity and mortality. Material and methods: study design, prospective observational hospital case study, place SPMC Bikaner. The study included 148 patients presenting with ROCM or were histological or KOX Mayo positive for mucormycosis between May 1, 2021 and April 30, 2022. Detailed history was taken and a local, ocular and complete systemic examination was conducted. Diagnostic nasal endoscopy was performed for all patients. Samples were collected for histopathological examination either through a swab for KOX Mayo or tissue biopsy to confirm the diagnosis. Radiological investigations included HRCT of the paranasal sinuses, orbit and brain, as well as MRI of the brain. Rhino-orbital mucormycosis included patients with orbital lesions with or without maxillary involvement. ROCM included patients with cavernous sinus and intracranial region involvement with or without orbit and maxillary involvement. Medical management included reversal of immunocompromised conditions and antifungal medication. The main drug used in the study was intravenous amphotericin B infused with 5% dextrose after initially hydrating the patient with 500 ml of normal saline. Retrobulbar amphotericin B was given in selected patients under all aseptic precautions. Surgical procedures included endoscopic debridement and exenteration. Complete ocular examinations were conducted at each follow-up visit and CT orbit was performed if necessary. Results showed male predominance. In associated risk factors, COVID positive status was predominant, followed by diabetes mellitus, steroid usage, and oxygen therapy. Orbital involvement predominant location was apex in our study, followed by inferior orbit, medial orbit, superior orbit, and diffuse involvement. 76 cases presented with stage ROCM 2, followed by 40 in 3, 20 in 4, and 12 in ROCM stage 1. As you can see, this picture shows conjunctival chemosis and lid edema, drooping of eyelid, proptosis in right eye, facial edema and discoloration of face, exposure keratopathy due to proptosis, and exenterated left eye. In medical management, all patients were given IVO amphotericin B, 26 were given retrobulbar amphotericin B, 145 patients underwent functional endoscopic sinus surgery, 15 underwent FES along with exenteration, and in 7 repeat FES was done. Outcome, 70% patients were discharged on posaconazole, 16.9% deaths were reported, 7.4% were declared cured, and almost 5% left against medical advice. The disease was staged according to the clinical extension following the staging proposed by the COSMIC study group. In most studies, there was male predominance. The majority of cases were between 51 and 60 years of age. It is rarely seen in children. In our study, we had one child. Diabetes mellitus contributed next to COVID-19. Most common signs and symptoms reported in COSMIC study were decreased vision, orbital or facial pain, facial edema, ptosis, and nasal discharge, while the most common sign and symptom in our study was ophthalmoplegia and nasal discharge respectively. In COSMIC study, medial wall was predominantly involved, while in our study, orbital apex was predominantly involved. COSMIC study showed that orbital exenteration does not significantly alter the outcome, and the study also confirmed this. Given the complex nature of ROCM, a multidisciplinary approach involving various specialists is crucial for optimal patient care. Collaboration between ophthalmologists, infectious disease specialists, endocrinologists, and other relevant healthcare professionals is necessary to ensure comprehensive and effective management of this condition. Thank you.
Thank you, Dr. Amita. I just want to ask you questions. What are the indications for retroviral epilepsy in your patient? And what are the indications in which patients did you give retroviral epilepsy B was given in your patient? In which patients? You have not given in all patients.
Only 26 selected patients.
What selected? What was it? What was your criteria of giving retroviral amphotericin B?
On which there was
Go on the line, please.
And in which there were severe orbital signs and symptoms and and the more aggressive visual outcome.
Okay, not on the basis of radiological findings. Okay, and any adverse effect did you find on that patient? Retroviral amphotericin B?
Ma'am, in some patients, nephrotoxicity was seen. To avoid that, proper hydration was given along with dextrose.
Any local side effect in the eye?
Ma'am, some patients complained of severe pain and discharge after the retrovalvular injection.
Okay, thank you. Kindly come and collect your certificate.
Dr. Akshita? Dr. Akshita Ghia is here? Yes. What's your name? Ask.
Good morning, one and all. Today I will be presenting a paper on a study to find out the prevalence of asthenopia among computer users in southern Rajasthan and effectiveness of educational intervention. Asthenopia defines as visual discomfort, tired eyes, light sensitivity, blurred vision, perceptual distortions, diplopia, or redness. It is also known as computer vision syndrome. With increased use of digital screens, these complaints have also been increased, but these symptoms are transient and relievable. Early identification of the risk factors and ruling out the refraction is very necessary to diagnose asthenopia. In this study, asthenopia diagnosis was made and educational intervention was explained, and then follow-up was done. This was a longitudinal educational interventional study which was conducted on 150 employees of various computer-based companies working for more than 5 hours per day over a time period of 3 months from diagnosis up to the follow-up. A questionnaire-based analysis was done. Visual acuity was tested to rule out any unmet need for refraction. The educational intervention which were provided by me was, first is the rule of 20-20-20, in which you have to look away from the screen and look at a distant object at about 20 feet distance for about 20 seconds after every 20-minute break from the screen. Positioning and distance of the digital screen was explained, in which the position of the screen was recommended slightly below the eye level. Screen brightness was recommended to keep up to 50% brightness. Frequent eye blinking was recommended to prevent dry eyes. Correct head posture with straight chair and anti-glare screens were recommended. Optimal lighting of the room was advised, and some relief measures were explained, like closing eyes and washing eyes during the symptoms. These were my results, in which the most participants belong to the young age group, which is 26 to 30 years old, which was 25.32%, and the least number of participants were from the 46 to 50-year-old age group. Among them, about 67.3% were males and 32.7% were females. And among them, maximum time of computer use of the employees were over 5 to 10 years, and minimum time of computer use was 10 to 15 years. There was a background variables before and after intervention which was noted. So the number of breaks which were less than 3, among them 110 employees were having symptoms, which was reduced to 88 after intervention, and the people taking more than 3 breaks, among them 40 were having symptoms, which was reduced to 31. Average distance of screen from the eyes, participants who were keeping screen at less than 20 centimeter distance, among them 26 were having symptoms, reduced to 5. Screen distance at 20 to 30 centimeter, among them 102 were having symptoms, reduced to 87. And for more than 30 centimeters, 22 were having symptoms, which was reduced to 50. Level of the screen was recommended later, but before them the participants who were using above the eye level, among them 16 were prevalent, which was reduced to 13 after the intervention. At the level of the the eye, 87 were prevalent, which was reduced to 64, and below the level of the eye, among them 47 were prevalent, which was reduced to 29. Symptoms and relief measures of asthenovia before and after intervention. The symptoms like headache, redness, ocular strain, bottling, and other symptoms were noted. Among them, headache was present in 99 participants, which was reduced to 84. Redness in 101, reduced to 99. Ocular strain in 128, reduced to 95, which was the most prevalent symptom. Bottling in 110, reduced to 98. Blurring of vision in 28, reduced to 14, which was the least prevalent symptom. Diplopia in 54, reduced to 50. Burning sensation in 70, reduced to 61. And dryness in the eyes, which was present in 66 participants, reduced to 58. These were the relief measures. Before instructing them, they were using relief measure like rubbing the eyes or closing the eyes. Rubbing the eyes was the most prevalent in 68% of the participants, and after the intervention was explained, closing the eyes was the most recommended method to get relief from the symptoms. Discussion. Prevalence of asthenovia in my study was 87.3%, similar to results seen in a study. The comparison of prevalence of digital eye strain due to increased digital screen use during lockdown period was conducted by Salal Khan et al. Most prevalent symptom was ocular strain, which was seen in 128 participants out of 150, and least prevalent symptom was blurring of vision, seen in 28 participants out of 150. There was a significant decrease in symptoms after educational intervention in a period of 3 months, which was 63.33% reduction, as provided in the study by Shoaib Arshad et al. On prevalence of asthenovia. There is a significant role of sitting position, distance, break in between the computer use for the incidence of asthenovia and concordance with a community-based study of asthenovia and computer operators conducted by Dinesh J. Bhandari et al. To conclude, I'd like to say early identification and intervention, which usually is easy and beneficial of asthenovia, can improve the quality of visual function for longer duration, since the symptoms are very common and the risk factors are identifiable and modifiable. Thank you.
Thank you, Dr. Asmitha. Did you measure the tear film, or it was just a symptom-based study?
Well, it was just a questionnaire-based study, so I just asked the question of dryness, whether the dryness is present.
But doesn't it look like very vague asthenotic symptoms, headaches, and watery, and there was no measurement done of tear meniscus or by any of the new instrumentation that is nowadays available?
Ma'am, since these methods will indicate only the dryness of the eyes, that's why I didn't use any method of.
So that is a good this thing, and we should educate everybody actually, even the school going and the college going children also. Okay, nice. Correct yourself.
Actually, we very commonly see that these people who complain of all these problems also have a habit of like late night work. So asking about that is also very important, because they must be also educated about the sleep cycle. They should take proper sleep, or else these whatever we do, these symptoms will not like be relieved.
Even the refractive errors, they might be having some diffractive errors or any other systemic problems. It can be hypertensive or any other problems. They can have thyroid, must be having dry eyes prior to their work, this thing also.
And systemic history was taken. So after ruling out, mostly patients didn't have any major systemic problem.
Right, come. Dr. Aneri is present. Who wants to come and present now? Come. What's your name?
Krishna.
Right, come. Kindly stick to your time.
Good morning, everyone. So today I'll be presenting a case report of typical graves of thermopathy in primary hypothyroidism. So Graves' ophthalmopathy, we all know, is the autoimmune inflammatory process which attacks orbital fibroblasts. It is present in 25 to 50% cases of hyperthyroidism, but only a few case reports are present for euthyroid and hypothyroid patients. So a 55-year-old man presented in our department with redness, watering, and mild pain and diminution of vision. The signs we observed were lid retraction, periorbital edema, bilateral axial proptosis, strabismus, binocular diplopia, and decrease in visual acuity, which was 6/24 in both eyes. The patient is a known case of primary hypothyroidism and is on levothyroxine therapy since 2 years. And there was no history of any ocular surgery, any injections, trauma, or hyperthyroid state and radioactive iodine therapy. This photo has been taken with the patient's consent, and we can see that there is lid retraction, chemosis, and periorbital edema, and also the typical signs of thyroid eye disease. I also measured the proptosis with the Hertel's exophthalmometer, and it was observed 25 and 26 mm in the right and left eye respectively. So the investigations I carried out were a complete blood examination and the thyroid function test, which showed euthyroid status of the patient because he was already on therapy, and ultrasound neck showed degenerative changes, which was suggestive of thyroiditis, and the fundus examination was normal. The radiological investigations were MRI and CT that I carried out, and it showed typical rectus muscle involvement with the enlargement of the belly and sparing the tendon. I also did the visual fields of the patient, which showed central and paracentral visual field defects. And this is a B scan and VEP, which shows increased latency. The result was that the patient was diagnosed with moderate and severe isolated Graves' ophthalmopathy with a background of Hashimoto thyroiditis. I managed the patient with starting intravenous methylprednisolone therapy for 3 days, and which was followed by oral steroids, 60 mg daily, and it was tapered over 2 months with progressive tapering of half dose every 2 weeks. So this is a picture of day 4 post IV MP, and this is 1 month post the treatment. The patient had a symptomatic relief, and there was improvement in the extraocular movements, and also on follow-up, I observed that there was arrest in the deterioration of visual acuity. So the management of Graves' ophthalmopathy is multidisciplinary, and it has to be managed very holistically. And medical management and surgical management both have to be taken into consideration. There have been no clear guidelines for this, but corticosteroid is the mainstream of treatment for mild to moderate cases, and patients with hypothyroidism can successfully be treated with steroids in a similar manner as Graves' ophthalmopathy with hyperthyroidism. Thank you.
What dose was methylprednisolone given to the patients?
Ma'am, it was 1 mg per kg.
And they were indoor? They were kept indoor? Or?
Yes, ma'am, they were kept indoor. And it was with the reference with the endocrinologist was also taken, and then the dose was instituted.
Okay, thank you. Kindly correct yourself.
Thank you.
What's your name? Kindly stick to your time.
पहले से while you are getting the certificate, you will be ready.
All are not present. Actually. Dr. Akshita is present?
Yes.
So, okay, be present next.
Good morning, everyone. Myself, Dr. Akila Jagar. I am presenting clinical profile of the patient with pseudoexfoliation syndrome undergoing cataract surgery. Introduction. The pseudoexfoliation syndrome, which is also termed as PAX, is an aging-related systemic disease manifesting itself primarily in the eyes, which is characterized by the accumulation of microscopic grayish-white granular amyloid-like protein fiber. The white fluffy material is seen on ocular tissue such as trabecular meshwork, the pupillary margin, the lens, the zonular fiber, and anterior iris, and occasionally the cornea and extraocular, including in the skin, heart, lung, liver, kidney, and elsewhere. An association between genetic polymorphism in the LOX1 gene and the disease is also known. The prevalence of PAX syndrome in Indian population is around 0.69 to 3.8%. Cataract is the leading cause of blindness and visual impairment in the elderly population. The pseudoexfoliation syndrome represents an independent additional hazard for the development of nuclear sclerosis and indication for the cataract surgery. As we have very few studies on intraoperative cataract surgical difficulties associated with the pseudoexfoliation syndrome, the present study is an effort to assess the clinical profile and associated intraoperative surgical difficulties. The materials and method. This is a prospective interventional hospital-based study which was done in ophthalmological department of SPMC Medical College between December 2022 to August 2023, including 68 consecutive cases of pseudoexfoliation syndrome undergoing manual small incision cataract surgery. The exclusion criteria were patient with corneal degeneration and corneal opacity in whom anterior segment assessment is difficult, those with the cataract due to uveitis, trauma or the systemic disease, patient not giving consent. All patients underwent complete ophthalmological evaluation, that is slit lamp examination, the tonometry, ophthalmoscopy before the surgery. At the end of the surgical process, the intraoperative difficulties were noted. Before participating in the study, the patient provided informed written consent. The result. So, table 1 is showing the socio-demographic data. In our study, most commonly age group above 81 was affected, which was around 26 patients, which approximately around 38.23%, with female predominance, with bilateral presentation. The most common site of distribution of pseudoexfoliation material was seen in pupillary margin, iris and lens, which was followed by the iris in 20 patients, followed by lens in 15 patients, and on pupillary margin in 10 patients. The most common intraoperative complication was rhexis extension, which was seen in 7 patients, followed by zonular dehiscence in 6, iridodylisis in 4, posterior capsule rupture in 3. Total 20 patients reported intraoperative complication. The discussion. In our study, the frequency of pseudoexfoliation syndrome was maximum in age group above 81 years, which was similar to a hospital-based study conducted by Gobeto et al. On the prevalence of pseudoexfoliation syndrome among patients scheduled for cataract surgery. In our study, gender-wise distribution of pseudoexfoliation syndrome showed female predominance, which was similar to the study conducted by Avramidis et al. However, some study shows no sex predominance, such as Arvind et al. Present study showed bilateral involvement of eyes in 45 patients, similar to the study conducted by Hammer et al. In our study, the pseudoexfoliation material was distributed on iris, pupil, and lens combined in 23 eyes and on the pupillary margin in 10 eyes, which was similar to the hospital-based study conducted by Joshi et al. The rate of complication in our study was about 29%. The most common intraoperative difficulty encountered was rhexis extension in 7 patients, which was not consistent with other studies such as conducted by Hemlata et al. Conclusion. Patients with pseudoexfoliation syndrome are at increased risk of intraoperative complication due to insufficient mydriasis, weak zonules, and instability of lens. Cataract with pseudoexfoliation is a challenging scenario to operate upon, but good postoperative visual outcome can be achieved with manual small incision cataract surgery by careful preoperative evaluation of risk factor and surgical plan, knowledge of and the ability to manage the complication. Thank you.
Thank you, Dr. Amrita. You nicely showed us the distribution of pseudoexfoliative material. Did you do gonioscopy in all patients? What about the angle deposition?
Ma'am, in our study, we were not able to perform gonioscopy. Only slit lamp examination was mainly done.
Okay, so glaucoma was not ruled out.
On trabecular meshwork, we were not.
IOP?
IOP was measured by using application tonometry.
Okay, and which IOL was implanted in all patients?
Political IOL, ma'am.
In the back or in sulcus? What?
It depends. Mainly it was was put in the sulcus, but if the surgery was going well, we kept in back.
What is the follow-up? Are you following up these patients?
Yes, ma'am. We are following them over 1 week, then after 4 weeks, and at 6 weeks, ma'am.
Thank you. Kindly come and collect the certificate.
इसमें क्या हो गया?
Dr. Akshita? Right. Kindly stick to your time.
Good morning.
Dr. Akshika Dhamija can present next.
Good morning, everyone. Today I'm going to present a paper based on the title of the comparative assessment of the optical quality in the small incision lenticle extraction, that is the SMILE, and the implantable columnar lens, which is the ICL. The introduction. As we all know, refractive surgery is defined as a surgical correction of refractive errors of the human eye. We have various numbers of surgical methods to correct the refractive errors, and over the last few decades, newer methods are also coming. The goal of refractive surgery is to correct the myopia by decreasing the refractive power of the eye and to obtain a safe, predictable, and stable desired refractive state. The refractive power of the eye is reduced by augmenting the anterior radius of the curvature, that is by flattening the curvature of the anterior corneal surface, or by insertion of the appropriate synthetic intraocular phakic lens. The SMILE Pro has come as a novel form of flapless refractive surgery for the correction of myopia and myopic astigmatism and has shown good results according to Blum et al. And Lee et al. In SMILE Pro, a femtosecond laser is used to create a thin intrastomal lenticle of tissue, which is then removed through a 2 to 4 mm peripheral corneal laser incision. The implantable columnar lens implantation was another promising way. These lens implants are used to treat moderate to high myopia with or without astigmatism and as an alternative method to the laser vision correction. And it has showed superior visual quality compared to the laser vision correction. Also, there is no risk of ectasia since this is edited technology and co-corneal stromal tissue is ablated. Unlike in the cataract surgery, the natural lens is not removed. The ICL is inserted directly posterior to the iris over the natural lens and incision in the eye. There is an increasing concern regarding the visual outcomes of the ICL and SMILE. Visual performance is defined by how well a visual task of interest can be performed by given individual or group of individuals. There are various parameters to assess this performance of the above described refractive surgery. In this study, we have included the population transfer function, which is the MTF, and the point spread function, which is the PSL, as a measure of the optical quality. Materials and methods. The study was a prospective cohort study. We recruited individuals with myopia and myopic astigmatism who underwent SMILE and SMILE Pro at our center from April 23 to July 23. The inclusion criteria was age more than or equal to 20 years, stable refractive error, less than minus 0.5 diopter change in the last 2 years, no contact lens use for the past 2 weeks. For the patient who underwent ICL, the minimum ACD measured from the endothelium was 2.8 mm and the minimum endothelial cell count was kept to be 2500 cells per millimeter square. For the patient who underwent SMILE, the minimum calculated residual stromal blade thickness was taken to be more than or equal to 280 microns. The exclusion criteria: any media opacity, history of any ocular surgery or trauma, moderate to severe dry eye syndrome, glaucoma, diabetes, hypertension, pathological myopia findings, retinal diseases, history of any prior systemic disease, pregnancy, or unstable refractive error, or due to any poor compliance of the patient. We have taken informed consent and it was approved by the ethics committee. The indication was surgery was according to the surgeon's clinical judgment. A sample size of 100 eyes were included, in which 50 eyes underwent SMILE Pro and less 50 eyes underwent ICL V4C. The study parameters, that is the MTF and the PSL parameters, we studied preoperatively and post-operatively on day 1, day 7, 1 month and 3 months follow-up. Specifically for the patients with relatively thin corneas, abnormal posterior corneal elevation or other irregular corneal tomography that indicates the risk of ectasia or situations that are not suitable to the refractive surgeries, the surgeon recommended ICL. Other patients had the surgery by themselves. The surgical techniques were considered with this. The biometric measures that were considered were the visual acuity, including the uncorrected and the corrected distance acuity, in logMAR values, standard setup examination and validated fundus examination, XLM, Biol Master, intraocular pressure, corneal tomography by Tempel or corneal topography by Atlas 9000 corneal topography system. Ocular wavefront analysis was done by iTrace. And for the ICL patients, the walt and the white-to-white were considered by the OCT. The MTF and PSF, basically these are the two parameters we have considered that were measured with the eye trace. MTF usually depends upon the ability of the cornea to transfer various levels of detail from the object to the image. And MTF measures the ability of the visual system to transfer different spatial frequencies. And the PSF is basically the representation of the eye's optical quality and can be used to evaluate like factors like aberration, scattering, and other factors. And PSF values near to 1 are good, and PSF values less than near to the smaller the sharper, the better is PSF. The statistical analysis plan results: a total of 50 patients completed the 3-month study, of whom 25 were ICL and 25 is SMILE. There was no significant difference between the parameters that we considered, but only the corneal thickness was more in the SMILE eyes and then the ICL. Preoperatively, there were no significant difference in the PSF and MTF between the SMILE and ICL group. This is a table showing the demographic data. The mean MTF in SMILE group declined slightly at 70s and 3 months after the surgery, but was similar to the preoperative values. And the mean MTF in the ICL group was slightly increased from 38.45 plus minus 9.47 CPD before surgery to 42.65 plus minus 7.03 CPD at 3 months follow-up, but was comparable to the preoperative. Same in the mean PSF in the ICL group was significantly lower than the preoperative values at all follow-ups. PSF was not significantly different between the SMILE and the ICL groups at 3 months after the surgery. The change in MTF and PSF from the preoperative period to 3 months following the operation were not significantly different between both these groups. Discussion. SMILE and ICL has been widely used in the correction of myopia and myopic astigmatism. The result showed that the MTF curve.
Kindly conclude.
The SMILE, the PSF parameters were almost similar in the preoperative and the postoperative values in the SMILE and ICL group, and the MTF values slightly increased in the initial time, but it then gradually sustained, and it was same in the preoperative and postoperative value.
So both the parameters are good. Like, what is the take-home message?
And the take-home message is these parameters basically help us to understand the aberrations the patient might be complaining, or to understand the outcomes of the refractive surgery that we are performing on the patient.
Take a certificate. Dr. Anshika Dhamija, right? Okay, present.
Good morning, everyone. I am Dr. Akshika Dhamija from SN Medical College. I am going to present a case report on effect of abiraterone on chronic central serous chorioretinopathy. So, introduction is CSCR, as we all know, is central serous chorioretinopathy, is acute or chronic neurosensory detachment of retina with or without associated detachment of artery with accumulation of subretinal fluid. Etiopathogenesis and risk factor. We all know that it's very common in type A personality. It mainly occurs in young adults, 20 to 50 years, hypertension, steroid intake, pregnancy, emotional stress, very important factor. Males affected more than females. There is no standard management for this. We mainly go for observation or placebo for 6 to 8 weeks. Nowadays, other experimental therapies, focal laser is tried, drugs like acetazolamide, rifampicin, abiraterone, bevacizumab, mifepristone, finasteride, all are experimental basis. My case report is a patient named Indra came to me on 17 August 2023. She was 45-year female. She complained of decreased vision and distorted images in left eye since 4 to 5 years. There were no past records available. Her best corrected visual acuity was 6 to 18. And you can see fundus photograph demonstrating CSR. This was her OCT image at presentation. Then I started on tablet abiraterone 25 mg BD for 1 month on 18th August after all the blood investigation and especially serum potassium. Within 1 month, patient showed impressive improvement in visual acuity and significant reduction in fluid levels. Patient maintained visual acuity and fluid levels even after 1 month of stoppage of the tablet. She recently came to me for follow-up after 1.5 months and still maintaining without the tablet. This was OCT image after 1 month. Explanation: oral epinephrine, as we all know, mineralocorticoid receptor antagonist. It acts on choroidal mineralocorticoid receptor or reduce choroidal vascular permeability. This is mainly experimental basis. There is no fixed final that this is treatment of CSR. Treatment with epinephrine has most published evidence to support its use in all oral therapies in treatment of CSSR. 5 prospective RCTs prove that epinephrine is superior to placebo. This is very good study. Ramesh Venkatesh et al. Concluded that epinephrine led to visual improvement and more rapid recovery. It also proved beneficial to other eye. Although most recent RCT VC trial, there is a trial VC trial which showed opposite evidence. But I conclude that if large RCTs are needed, we can have good treatment for CSCR, as 1 in 1 lakh patients are affected by CSCR and it's a serious problem. So if we get a conclusive treatment, then it's very beneficial.
Was anything else given to the patient other than
No, ma'am, she was already on naproxen. I did only tablet epinephrine. For 4 to 5 years, she was going to everywhere, every doctor, but she was not getting any treatment.
So, macular functions have to be assessed properly because even after resolution of CSR, patients keep on having those symptoms.
But she was not having any subjective complaint. Before that, her main subjective complaint was dyschromatopsia and distorted images. She was not having any complaint.
So post-op, after the treatment also, we have to keep on following these patients with macular.
Thank you.
Dr. Ankita Singh will come next.
Good morning, everyone. I am presenting the clinical profile of corneal ulcer at Tertiary Care Hospital in Northwest Rajasthan. Corneal ulcer is an inflammatory or more seriously infective condition of cornea involving disruption of its epithelial layer with involvement of the corneal stroma. It is a manifestation of infectious keratitis due to involvement of organisms that cause necrosis and pus formation in corneal tissue. Corneal infections play a significant role in causing monocular blindness and visual impairment. The present study is an effort to assess the clinical profile of corneal ulcers at Tertiary Care Center. Study design: it is a prospective longitudinal and observational study conducted for 2 years from October 2021 to 2023 at Department of Ophthalmology, SPMC Bikaner. Included patients diagnosed and treated for corneal ulcers. 100 consecutive cases of corneal ulcer were enrolled in the study. Patients not willing to give consent for the study were excluded. Appropriate written informed consent was obtained from all the patients. Data collection included socio-demographic details, anthropometry, clinical profile, visual acuity, slit lamp examination to note the size of ulcer, its depth, extent of infiltrates, corneal thinning, height of hypopyon, and scleral extension. Corneal scraping was taken only from 60 cases under full aseptic measures and sent to the microbiology department. Table 1 shows socio-demographic data. Maximum proportion of the patients were 41 to 60 year old. Maximum males 58%, from rural areas 75%, and the most common occupation was farming, that is 32%. Table 2 shows chief complaint. Most common chief complaint was foreign body sensation followed by watering of the eye. Table 3 shows the positive agent. Most common positive agent was vegetative matter followed by wooden stick. Most common ulcer location was central. Most of the cases had an amoeboid shape, and superficial stromal ulceration was noted in 48% of the cases. Most common bacteria isolated from the culture was Staphylococci followed by Streptococci, and most common fungal isolate was Aspergillus fumigatus. Visual outcome. At 3-month follow-up, most of the cases had visual outcome 6/62 peer present.
2% had inaccurate projection of the rays, and 8% of the patient who did not perceive any light. This is a diagrammatic representation of different type of the corneal ulcers. Discussion. In our study, maximum proportion of the patients were male, and their most common occupation was farming, similar to the study conducted by Mohod et al. And Srinivasan et al. In our study, 41% of ulcers were central and 27% were paracentral in location, similar to the study by Mehta and Mehta. 48% of the cases were attributed to fungal infection, followed by bacterial infection, similar to the study by Oletev et al. In our study, the most prevalent bacterial isolates were Staphylococci, followed by Streptococci, similar to the study by Lencini and Badavale and Subel et al. But some studies reported Pseudomonas as a more common bacterium than Staph aureus. In our study, 27% fungal positive samples were positive for Aspergillus fumigatus, followed by Fusarium, similar to the study by Joshi et al. And Tiwari et al. Conclusion. Fungal etiology was a more common cause of corneal ulcer, followed by bacterial etiology. Timely medical attention, that is early microbiological diagnosis, antibiotic susceptibility testing, correlated with improved visual outcome, emphasizing the importance of early intervention. Tailored regional studies like ours provide critical insights for the targeted preventive measures, guiding public health initiative and reducing economic burden of blindness. Thank you.
Perforated corneal ulcers were excluded?
Yes, ma'am.
Were excluded?
Yes, ma'am.
So all the patients were medically managed?
Yes, ma'am. Medically managed.
Okay, nice study with a good number of patients. Thank you. Kindly come and collect yourself.
Dr. Deepika can come. Dr. Deepika is present. Dr. Gaurav Joshi. Dr. Ajarina, you can present next.
Good morning, everyone. My name is Dr. Gaurav Joshi. I am presenting the paper on the association of the glycosylated hemoglobin, that is HbA1c level, with the diabetic retinopathy in type 2 diabetes patient at Tertiary Care Center. The introduction: diabetes retinopathy is a chronic, progressive, potentially sight-threatening disease of the retinal microvasculature associated with the prolonged hyperglycemia and associated with other conditions and related to diabetes mellitus such as the hypertension. In India, 20% of the type 2 diabetes mellitus population is estimated to develop the diabetic retinopathy, which suggests that by 2025 nearly 11.4 million adults with the diabetes may develop the diabetic retinopathy. The main risk factor associated with the earlier onset and rapid progression of the retinopathy are duration of the diabetes, high blood sugar level, arterial hypertension, hyperlipidemia, severe nephropathy. Other risk factors are smoking, obesity, and the anemia. HbA1c is an N-terminal valent residue of the erythrocyte hemoglobin become irreversible glycosylated in the population of the circulating glucose concentration, and the resultant product is referred as the HbA1c. As the lifespan of the glycosylated hemoglobin is 120 days, unlike fasting blood sugar and PPBS is given as a long-term glycemic values, as it is the best indicator of the glycemic value of the past 8 to 12 weeks. It is chosen to help as to foresee and tissue damage and its progression. The relation between the glucose control and the development of the diabetic complication remain an area of the active investigation. aim and objective to find out the association of the glycosylated hemoglobin level with the diabetic retinopathy in type 2 diabetes patient at the tertiary care hospital. The material and method, it is a hospital-based prospective observation study to assess the association of the HbA1c level with the diabetic retinopathy in the type 2 diabetes patient. Patient having type 2 diabetes with the diabetic retinopathy of the either sex and those who give the written informed consent were included in the study. The number of the subjects recruited into the study were 160. Each patient underwent a complete ophthalmic examination, including the clinical examination and the lab investigation, including the visual acuity, fundus examination by direct and indirect ophthalmoscopy, and plus 90D slit lamp by microscopy. After the acquisition of the pupil, fundus photography and the ocular tomography done. Diabetic retinopathy classified according to the earlier treatment diabetic retinopathy study classification. After the confirmation of the diagnosis and the obtaining consent from the patient, 2 ml blood drawn in the EDTA vial labeled from number 1 to 160 or vial and sent to the central laboratory of for the FBS and the HbA1c. Glycosylated HbA1c was measured by the autoanalyzer and expressed in the percentage. The continuous data was presented as mean plus minus standard deviation or the median and inner quartile range as the appropriate. All calculations were performed using SPSS version 22. The result was that there was the 92 male and the 68 females. The mild NPDR has the 44, that is 27.5%. The moderate have 56, 35%. Severe 40, 25%, and the PDR developed the 20% from the total 160 patients. The HbA1c range, as per the range, is 6.5 to 8.5. This is the table in which the mild, moderate, and severe NPDR and the PDR is calculated. The type of the retinopathy, the mean mild NPDR has the 8.2, which is 0.88 standard deviation. Moderate NPDR 8.93 and 1.24 standard deviation. Severe NPDR have the 11.67 and 1.11 standard deviation. In the conclusion, the maximum number of the patients were developed with diabetic retinopathy after 60 years of the life and after 10 years of duration of the disease. Glycosylated hemoglobin value showed the increasing trend according to the severity of the diabetic retinopathy cases. Hence, prevalence and the severity of diabetic retinopathy increased with the increasing level of the HbA1c. All diabetic retinopathy groups are considered and the HbA1c and the duration of the diabetes are measured predictor of the complications, like vision-threatening complications. Thank you. Yes. No, CME was not.
Out of the 160 patients, one patient had cystoid macular edema, CME.
And some patients in severe
Any association with this HbA1c with that macular
yes,
edema, did you find?
who developed the severe PDR, severe NPDR or the PDR, they in that patients developed the CME.
Okay, thank you. Kindly come and collect your certificate, Dr. Bombay.
Dr. Hajari Ramrai.
Good morning, everyone.
Next,
I am
Dr.
presenting
Zeba.
a paper.
IDB ready.
An international study of pre and post-operative changes in intraocular patient Intraocular pressure and anterior chamber depth after phacoemulsification with intraocular lens implantation I greater than 23.5 after intraocular lens. Introduction. Cataract and glaucoma are ranked as the leading cause of blindness worldwide. In developed countries, glaucoma is second leading cause of irreversible blindness after every retinopathy, and this burden tends to increase as population ages. Patients of cataract with hypermetropic eye usually have a thick lens that goes to pupillary block and consequence angle closure. Its removal allows for expansion of anterior chamber dimension and angle width, promoting aqueous humor outflow and intraocular pressure reduction. Also, even when compared with laser peripheral eye, this treatment portfolio presents with further advantage, better long-term intraocular pressure control, laser need for long-term medication in order to maintain an optimal intraocular pressure, wider angle and fewer peripheral anterior synovial formation. Cataract extraction is increasing considered for primary angle closure glaucoma management owing to its capacity to restore the anatomy of anterior chamber with lens extraction, often without the need for further medication. Although cataract surgery and intraocular lens implantation lead to clinically evident deepening of anterior chamber, decrease of intraocular pressure and widening of iridocorneal angle. Purpose of study. The purpose of this study to evaluate quantification of changes in intraocular pressure, anterior chamber depth after phacoemulsification with intraocular lens implantation in the eye greater than 23.5 after intraocular lens. To evaluate whether changes in anterior chamber depth are helpful in bringing down intraocular pressure to optimal lens so that further glaucomatous consequence in high pressure eye can be prevented. And to study pre-operative and post-operative changes in intraocular pressure and anterior chamber depth after phacoemulsification with intraocular lens implantation eye greater than 23.5 after intraocular lens. Material and methods. This research was a prospective interventional study conducted among patients underwent for phacoemulsification with intraocular lens implantation in the eye greater than 23.5 after intraocular lens. A total 48 eyes of 48 patients were included in the study. Anterior chamber depth was measured by Iodomaster 500 and IOP was measured by Goldmann Applanation Tonometer. Data analysis was done using licensed SPSS software version 21.0. Result: the table showing socio-demographic and clinical profile of study. Participant. Comparison of anterior chamber depth and IOP before and after surgery. Anterior chamber depth and IOP pre-op and post-operative. In the present study, mean age of study participant was 62.7 plus minus 11.3 years. Out of the 48 participants, 27 were female and 21 were male. 30 were operated for right eye. Pre and post-operative anterior chamber depth was 3.8 plus minus 0.73 mm and 4.1 plus minus 0.6.7 mm respectively. P-value is greater than P-value is less than 0.001. Pre and post-operative IOP was 15.7 plus minus 2.9 mmHg and 13.6 plus minus 2.6 mmHg respectively. P-value is less than 0.001. Conclusion: our study concluded that anterior chamber depth was statistically significant increase and IOP was statistically significant decrease after phacoemulsification with intraocular lens implantation in eye greater than 23.5 after intraocular lens. Thank you.
Doctor, why was this value of 23.5 chosen? And was a preoperative gonioscopy also done for all these cases? Because we very commonly see that angle closure glaucoma can be mostly it's diagnosed when the intraocular pressures are in normal range. And after the surgery, we can see a rise in IOP also. So you should also have thought about it.
No, sir, volumes did not done, but I take the patient mostly hypermetropic.
So after cataract, the refractive diagnosis changes. they don't remain in hypermetropes. They become patient who will be having cataract. Diagnosis becomes cataract. So hypermetropy is fixed, then we should look for the axial lens.
Basically, I was also about us. What is your inclusion criteria? Did you do excellence, lens thickness, any inclusion criteria for your patients? Or just
Normal cataract patient and
cataractus, or did you do clear lens extraction also?
cataract patient.
Cataractus patient. Any patient, any cataractus patient was included whose eye underperforming more than are equals to 23.5. So you told us about YAC PI, YAC iridotomy also. Did you do any YAC PI in your patient? Don't you also? So just all patients are included, so he said. Not on the basis of excellence and thickness on whole basis was. Okay. Thank you, kindly come and correct your certificate.
Dr. Jyoti, can be ready for the next? Dr. Jyoti is here.
Good morning, everyone. I'm Dr. Siva, presenting a paper on the topic of ocular trauma, how it is affecting economic, social, and psychological aspect of an individual living with a traumatic eye. These are all the headings we will cover our topic under with. So, as per the WHO or Blindness Data Bank, approximately 55 million eye injuries occur worldwide annually. In India, over 50 million people suffer from blindness. Among them, 1.2% cases of blindness are caused by the avoidable ocular injuries. Ocular injury is a significant cause of blindness worldwide that negatively affect the quality of life of patients, their families, their socio-economic status, and their psychosocial well-beings. So, aim of this study is to assess the outcome of the ocular trauma in terms of visual disability, its effect on socio-economic, psychological aspect among patients surviving with a traumatic eye. Objective of this study is to provide the recent epidemiological data on recent trend of the ocular trauma, examining the presence of visual damage due to ocular trauma and assess the visual outcomes. This is a hospital-based longitudinal observational study. 200 patients were included who presented with the eye injury through the OPD or the emergency route. The patient underwent a complete ophthalmological examination, including the visual acuity slit lamp examination and fundoscopy where possible. So the inclusion criteria was the patient with the ocular injury, mainly the globe involving injury and only anterior segment involving injuries, reporting to the casualty or the ophthalmology OPD, agreed to give written consent. 18 to 60-year age group were included because we believe that this is the age group who make the pillar of the society for the social and the economic aspect. Exclusion criteria was patients who having the pre-existing vision-threatening ocular diseases like glaucoma, aggravated macular degeneration, etc. Injury in blind eye or atrophied eye, comatose or unconscious patient who was not able to give detailed history, and patients who were not agreed to attend regular follow-ups were excluded. Total 200 patients with ocular trauma present prior informed consent were obtained, and the detailed history was taken about all the demographic details. A specific history of trauma were taken, and all the information was collected in a pre-designed performer. A detailed interview of the enrolled patient conducted at the 3-month follow-up visit to know about the impact of ocular trauma on different aspects of the patients. Study tools were like following: detailed history of trauma events, Snellen charts for the visual acuity slit lamp examination for the local detailed examination, direct and indirect ophthalmoscopic examination, EQ5D5 questionnaire for the life of quality assessment, the detailed interview about the different aspect of the patient. This is the EQ5D5 is a self-assessed health-related quality of life questionnaire that measure the quality of life on 5-component scale: mobility, self-care, visual activity, pain, discomfort, anxiety, and depression. So my results was like 200 out of 200 patients, majority of patients, 67% were male and 33% were female. Most vulnerable age group was 18 to 30 year age. Majority of patients, 30% patients were illiterate in the study. Among all the patients, 42% were student, and rest was engaged in different occupations like farmer, laborer, housemakers, or in service. Maximum patient belong to the 62% patient belong to the rural background.
24% patient accounted with the occupational injuries, and among the non-occupational injury, the majority of the patient reported with the sports-related injury. So 74% patient reported with the mechanical trauma. Among the mechanical trauma, the most common mode of injury was the wooden related injury. Most the patient presented with us was the visual acuity with perception of light, hand movement or finger count only. Open globe injuries were the common, and the penetrating laceration was the commonest with the 76 patient, 38%. These are the compilation of all the demographic data of the patients. Quality of life assessed, and the result shows like mobility and self-care is not affected much by the ocular trauma only, but the pain, discomfort and anxiety depression was at the significant level after the post-trauma. So a detailed interview conducted where the people were asked about the following domains of the life: workplace life, married and relationship status life, or the social life. Their response were noted on the scale of not at all, a little bit, moderately, quite a bit or extremely, that correspond to the score of 0 to 4. These are the compilation of the data as per the response of the patients, and it's concluded that trauma significantly affect the work life of the 61% patients, those who face the discrimination on workplace, school, or on the basis of their physical appearance. Around 11% faces the extreme difficulty that they lost their job or didn't get any job that lead to financial crisis to them. 59% patients were struggling with the relationship problem. 7% got divorced. 78% patients having anxiety, depression, self-doubt. Among 73% patients were not seeking any psychiatric treatment due to the social stigma. 70% patients start to avoid social events because of the self-doubt and lack of confidence. Ocular trauma influences the life quality and mental well-being of the patient. The financial cost associated with the ocular trauma and economic burden on the healthcare system also resulting from the cost of treatment and rehabilitation services. Raising the awareness, implementing prevention measures are highly justified. On the other hand, accepting the eye injury and living with its result is a serious process for people, especially the young generation. Therefore, psychological and psychiatric support is needed in the following objects suffered from the eye traumas. Thank you.
Did the severity of injury also add to your findings?
Sir, mostly the severity of injury is assessed by the visual acuity of the patients. So the patients with the hand movements or the finger counting were the most severely injured patients, and the only anterior segment injuries were involved. The posterior segment injuries were excluded in the my study.
Few patients can have a very badly severed, badly looking eye and relatively good vision.
So actually this is the criteria, not on just the clinical presentation of the trauma is not included, the severity included on the basis of the visual acuity of the patients.
Good talk and collect your certificate. So after Dr. Jyoti, Dr. Kavita is here. Okay, so you present after that. And Dr. Mansi is here. Dr. Aneri. And Dr. Deepika. Okay.
Good morning everyone, I am Dr. Shilena. I am here to present a study to evaluate long-term outcomes of hidden patch graft and corneal fistulas. What is a corneal fistula? Corneal fistula is a communication between the AC and the corneal surface, follows either the trauma or ulcer perforation. Does not heal spontaneously because of poor tissue opposition and the persistent aqueous humor flow. If a corneal fistula persists, it can lead to pars, secondary glaucoma, recurrent hypertonic, thesis bulbi, endophthalmitis, and panophthalmitis. My surgical approaches are alternatives are conjunctival graft, which shows the reduced visual acuity, bandage contact lens, and cyanoacrylate glue, which can be cause foreign body sensation and toxic to the corneal endothelium. Tarsotherapy causes the cosmetic inacceptance and patient dissatisfaction. EMG shows the difficulty to handle, it is non-transparent and flaccid. Complete corneal grafting shows a higher chance of endothelial rejection and require extensive use of topical and systemic steroids. Plain patch graft is a good alternative for the impending perforation or small corneal fistula because it is a cost-effective, easily available, autologous nature of tissue, minimal post-operative inflammation, and less chances of rejection. Prevents the urgent need of penetrating keratoplasties. My study type is a prospective interventional study. We included 10 patients with corneal fistulas less than 2 mm. Our study time is 6 months from 1st May 2022 to 31st November 2022. My aim is to evaluate long-term outcomes of plain patch graft in a corneal fistula less than 2 mm to evaluate the time of healing and stability of corneal surface. Our inclusion criteria are corneal fistula less than 2 mm with positive CIDL signs and the patient who give well informed written consent. Patients were excluded which corneal fistulas are more than 2 mm and other ocular and systemic disorder and the non-capitative patients. Method is plain patch graft size measure using caliper. Supratemporal conjunctiva more than 1 mm is taken. Linear parietal is done and tinen tissue marked using caliper. Incision over the tinen tissue corresponding to the size of the conjunctival marking is that size. The cut edges of conjunctiva are approximated. The procedure graft is trimmed to match the size and shape of the defect. The graft is then sutured with the help of the multiple interpreted 10-0 nylon sutures. At the end of the procedure, anterior chamber is formed with the hair. A preoperative and postoperative picture on day 7. In our study, 10 cases are taken, in which 6 were females and 4 were males. On final follow-up, 80% patients successfully achieved flow continuity and anterior chamber was formed, and also fluorescent leak was not in 80% of patients. Anterior chamber formation was observed on day 1 of grafting, in which 8 patients showed no leak on status test. In our study, BCVA is also improved with mean of 0.311 to 0.118 with a p-value of 0.011. Baseline BCVA is not a statistically significant difference and difference was statistically highly significant post-operatively. Our discussion is open. Corneal fistulas are abnormal communication between anterior chamber and corneal surface. If left untreated, may lead to many complications. The primary goal of treating the corneal perforation is restore the eye integrity and promote healing for potential future corneal transplantation. In developing countries, addressing issues challenging due to cost limitations, scarcity of donor cornea, and maintaining eye bank and stem cell laboratories. Plain patch graft has shown the promising in fulfilling these objectives because it has adapted for small to medium-sized corneal perforation, offering advantage over improved BCVA, IOP, minimal post-operative inflammation, reduced risk of rejection, cost-effective, relatively simple surgical technique, minimize the potential complication with tissue adhesive, post-operative inflammation, vascularization, and ocular discomforts. A conclusion in this study, we observed TPG has a good success rate, cost-effective, improved BCVA, IOP, easy availability, autologous nature of tissue that causes less rejection, and minimal post-operative inflammation and simple surgical technique. Thank you.
Do you think that glue must have helped in these cases?
Yes, sir.
The glue must have helped in these cases because they are less than 2 millimeter.
Yes, ma'am, it can, but it can cause inflammation, infection, iritis, it may lead to this problem. Change shows the much more beneficial in these cases.
And what about corneal opacity and scarring and after using Tien's tissue?
No, ma'am, it shows very good results, no scarring.
No
After 6
opacity?
months. After 6 months.
After 6 months.
In follow-up, yes, ma'am.
And what did you give for the follow-up period? You gave steroids or something?
Yes, ma'am. Steroids, antibiotics.
You see the perforations that we see which can be treated with this treatment, those corneas are already scarred and they have a chronic pathology associated with them.
Yes, sir. We only taken these cases which are the non-healing corneal fistulas and patient.
So all these, most of these cases will have a diffuse full thickness corneal operation.
Yes.
Can you get certificate?
everyone, myself Dr. Kavita, and presenting a comparative study to evaluate incidence of dry eye in patients underwent cataract to VR surgery after giving tablet doxycycline and vitamin C as compared to other oral antibiotics under the guidance of Dr. Sandeep Harwal. Introduction. Dry eye disease is a chronic disease by which millions of people affected worldwide. Dry eye syndrome is multiple disease affecting tear film, causing ocular discomfort, visual disturbance, tear film instability with massive damage to the ocular surface. The main cause of dry eye after ocular surgeries is dysfunction of meibomian glands. Doxycycline is a known treatment for meibomian gland disease, which is a major risk factor for development of dry eye disease. Vitamin C has anti-inflammatory, antioxidative, immune modulator properties, which can be helpful in prevention of dry eye. In this study, we are evaluating the effectiveness of post-operative tablet doxy and vitamin C in comparison of other oral antibiotics for preventing post-operative dry eye in cataract or VR surgery. Aim of this study to compare incidence of dry eye after cataract or VR surgery, giving the post-operative treatment doxycycline, oral doxycycline and tablet vitamin C in compared to other oral antibiotics to prevent dry eye syndrome and improve functional recovery after cataract or VR surgery. Pathogenesis of dry eye after cataract surgery, repeated drying irrigation, eye drops using preservative including povidone iodine during pen drape, phototoxicity, surgical trauma during applying speculum, ocular surface trauma, corneal epithelium, conjunctival epithelium, and incisional nerve damage during formation main wound, sideboard. Method, this is the prospective observational study. Patients are taken who underwent cataract surgery group 1 and patients underwent VR surgery group 2. All patients full examination done, BCVA, slit lamp examination, fundus examination. In this study, parameter for documenting dry eye is Simmer test and Kuchneri, asking to patient watering and foreign body sensation. In this study, Simmer test strip was used for diagnosis, which is a common OPD test to diagnose dry eyes. Simmer strip waiting at the end of 5 minutes was taken. Simmer test was done at baseline before surgery and 1 month after surgery. Simmer test value less than 10 mm was taken as dry eye. In this study, 120 patients are total taken. 60 patients underwent phaco surgery and 60 patients VR surgery. Group 1A, 1 was divided further 1A, 1B. 30 patients received tablet doxycycline and 1B received other oral antibiotics. Inclusion criteria: patients are taken more than 18 years old, patients who give well-informed written consent, and patients visually significant cataract group 1, and patients have a posterior segment pathology that require VR surgery group 2, or patients who are scheduled for silicone or removal surgery group 2. Exclusion criteria: patients with pre-existing dry eye, Simmer will be less than 10 mm, Sjogren's syndrome patients, pre-existing ocular diseases like glaucoma, disorder of lead nasolacrimal pathway, ocular allergies. Results showing incidence in group 1A, 0% after giving doxy and tablet vitamin C, and patient taking other oral antibiotics, 15% patients showing dry eye. Same as in VR surgery, patients given doxy vitamin C, 0% incidence, and no taken doxy and CMC, 10% incidence. In cataract surgery patient post-operatively not given doxy and CMC, significantly low Simmer value, showing T value 0.047. Discussion: the tear film cornea interface forms the strongest reflecting surface of the eye. Any abnormality in the tear film causes suboptimal visual performance. In this study, it is validated that dry eye symptoms and ocular surface damage may occur after cataract surgery or VR surgery. 4CAT-L study have reported abnormal meibomian gland function as a cause of dry eye related to cataract surgery, and James et al. Study have found thinning of lipid layer after cataract surgery. These changes in the precorneal tear film make it less stable, leading to development of dry eye. Discussion: doxycycline is a non-treatment for meibomian gland disease, which is a major risk factor for development of dry eye. Inflammatory response leading to elevated production of free radicals, proteolytic enzymes, cyclooxygenase is also a key factor in development of dry eye. By inhibiting pro-inflammatory mediators, cytokines, enzymes, interleukin-1 beta, TNF-alpha, and matrix melanoproteinases, doxycycline is a potent anti-inflammatory. Only few studies on the influence of vitrectomy are available, even though clinical practice experience shows that it is a quite frequent problem in such patients. During pars plana vitrectomy, conjunctiva is traumatized and continuity interrupted, especially in scleral depression is used to surgery in the region of vitreous space. Conjunctival goblet cell density was significantly reduced in postoperative condition in VR surgery, which can in turn to lead dry eye disease. Human tear film containing vitamin C level, which may be helpful for antioxidative and anti-inflammatory defense on the ocular surface. Conclusion is the studies dry eye seem to be a common complaint post-cataract surgery as well as in VR surgery that significantly affect patients' satisfaction despite visual recovery. In light of high incidence of dry eye following cataract or VR surgery, we recommended the use of doxycycline and tablet vitamin C as post-operative treatment in order to avoid dry eye-related complications following surgery and provide symptomatic relief to patients. Thank you.
So what pharmacology group does doxycycline belong?
Tetracycline.
Do you think that it will be effective after cataract surgery? Tetracycline group, does it have a good penetration of the rapis barrier, and will it be a good, a safe drug to be given after cataract surgery or after VR surgery?
Yes, ma'am. Some patients have abdominal discomfort.
I am just talking about the complication related to cataract and VR. Are tetracyclines given after cataract and VR surgeries as a line of drug of choice?
No, drug of choice.
So it should be just given to avoid dry eyes?
Yes, ma'am. Complications of dry eye will decrease to this time.
So, like, we very commonly see that after routine cataract surgery or even a VR surgery, the patients stop touching their eyes at all. They, for months altogether, they don't even touch their eyelids. So, which causes uveitis. So, actually, evaporative type of dry is very common due to uveitis after any eye surgeries in this part of our country. So doxycycline will definitely help for uveitis, but there are other treatments also which should be advised.
Director certificate? Dr. Kavita, right? Dr. Mansi and Dr. Aneli and Dr. Deepika is not here, right? The last presenter of the session, Dr. Mansi Sonwar.
Good morning everyone. I am here, Dr. Mansi Sombar, to present on the topic of comparison of OCTA parameters before and after intravitreal injection ranibizumab in retinal vein occlusion patients under the guidance of Dr. Sanjeev Naniwal sir, Senior Professor, SMS Medical College and Hospital. Optical coherence tomography angiography is a non-invasive, quick and three-dimensional method for imaging. It does not require dye injection. It enables a high resolution and rapid imaging of bloodstream in various layers of retina and helps in analysis of distinct layer of retina, including the superficial and deep capillary plexus. The in-phase imaging of the OCTA enables us to image the normal FAZ area and its changes in macular involvement. It uses the split spectrum amplitude decorrelation angiography algorithm to detect its-right movement. The principle of it includes the optical word itself says means it uses light. Coherence means two light waves with constant phase difference. Tomography means imaging of sections. Angiography means imaging of blood vessels. What are the OCTA findings? We can see in a retinal vein occlusion patient, capillary non-perfusion corresponding to area involved, FAZ enlargement, microvascular abnormalities, vascular congestion, collateral formation, neovascularization, macular edema. Retinal vein occlusion is the most common cause of retinal vascular disease and vision loss. The vision loss is made most commonly because of macular edema. Macular edema is caused by the release of substances that enhance vascular permeability such as VEGF. VEGF is produced in the retina because of the deterioration of the tight junctions between capillary endothelial vessels and adhesions between the vitreous and the retina, damaging the blood-retinal barrier. So, anti-VEGF drugs are used frequently in the treatment of macular edema due to RVO. For this study, we evaluated the effect of anti-VEGF treatment in eye of retinal vein occlusion using OCTA by comparing the baseline and after treatment findings of the same eye with the contralateral eye findings. We assessed the vessel density in superficial capillary plexus, CRT, FZ area by OCTA machine in patients who underwent anti-VEGF treatment. The aims of my study were to study the changes in OCTA angiography biomarkers after anti-VEGF injection in macular edema patient due to retinal vein occlusion. Objectives include pre and post-injection analysis of CRT, FZ area, and the vessel density in superficial layer of the retina. Selection criteria: inclusion group, age group 35 to 85 years of age with a recent episode of RVO and presence of macular edema and a minimum follow-up of 3 months. Patients who are willing to participate in the study with a well-informed consent. Exclusion criteria: uncooperative patient, uveitis, uncontrolled glaucoma, vitreous hemorrhage, media opacity due to cataract, poor signal strength less than 2, a previous history of anti-VEGF, ocular infection, ocular trauma and surgery. Study methodology: it is a single standard intervention study. Well-informed consent were taken. The study was conducted under 30 patients, including 18 men and 12 women, who require anti-VEGF injection in the single eye with macular edema due to RVO, which is diagnosed by fundoscopy and spectral domain OCT. A brief history and a complete ocular examination was done. OCT angiography parameters was analyzed, and a follow-up was done at 1 month and 3 months, and stat analysis was done. The results: central retinal thickness, we can see that pre-injection there is, after post-injection of 3 months, there is significant decrease in central retinal thickness. In parafoveal vessel density in superficial capillary plexus, the post-injection parameter of vessel density does not decrease significantly. The FZ area, there is a significant decrease in FZ area post-injection 3 months in the RVO eye. This is the image showing the before treatment and after treatment. OCTA image showing the disruption of parafoveal vascular arcade and FZ with cystoid space in the superficial capillary plexus in the figure 1, and the figure 2 showing the after treatment of 3 months of treatment. There is an intact vascular arcade with resolution of macular edema. Discussion: a significant decrease has been shown in patients of RVO and macular edema treated with intravitreal injections when compared with the unaffected eye of patient before treatment. We found the FZ area in RVO eye to be significantly larger than those in the fellow eye. FZ area post-injection improved significantly. In the RVO eye, we also noted a decrease in vascular densities at the parafoveal superficial capillary plexus compared to those in the treated and contralateral eye, but the change after intravitreal injection was not so significant. The number of cysts also decreased in both the plexus. The results of our study shows concordance with the study done by Dogan NC et al., which shows after anti-VEGF injection there is significant decrease in CRT and improvement in BCVA. Conclusion: the OCTA shows a significant regression of macular edema, reduced capillary disruption in cyst, and parafoveal vascular arcade improvement. Thus, OCTA enable us a qualitative as well as a quantitative evaluation during the follow-up of patient treating with RVO, thus enabling us to predict the visual prognosis in RVO patient treated with anti-VEGF injections. So these are the references. Thank you.
So, like, the age also has to do something with the prognosis of these patients with CR or DR, final outcome of the treatment.
So we can say that because itself, with the increasing age, there is the increasing risk for RVO in patient also. So if we treat it in the earlier age group, so it will prevent. It will help in a good visual prognosis also.
So young patients tend to have a better prognosis.
certificate? everybody, and so we conclude the session. There are 2 absentees with presentations by all.
सामने चढ़ना एक बार सामने
Thank you.
With me is Dr. Arvind Chauhan. Dr. Subhaya is not here. So let us first take the attendance who all are present and who are not present. Dr. Monica Bagla. Swati Thakur. Dr. Silika Gupta. Dr. Vijay Singh Mangwana. Mangawa. Dr. Rucha Pathara, Dr. Sapna Gupta, Dr. Rishabh Gupta, Dr. Sahil Jain, Dr. Nidhi Meena, Dr. Vivek Goyal, Dr. Sehasveer Singh Pannu, Dr. Sophia Chaudhary, Dr. Priyanka Sunda, Dr. Ritu Kala.
Yes.
Dr. Monica is here. Let's start with Dr. Monica Bagla. Your time is 6 minutes. Please stick to time.
Good morning, respected panel judges and my fellow colleagues. I am Dr. Monica Bagla from SHRC Jaipur. I will be presenting my paper on comparison of 3 different types of hydration techniques in clear corneal, uniplanar incision, phacoemulsification surgery. As we all know that in phacoemulsification surgery, we start the surgery by making a clear corneal wound, which is approximately 2.8 mm in size, and the integrity of that corneal wound is extremely important to achieve excellent outcomes during as well as after the phacoemulsification surgery. After completion of phacoemulsification of the nucleus and intraocular lens insertion, a watertight seal of corneal wound is needed to prevent any egress of interior chamber contents outside the eye, thereby preventing the hypotomy, as well as it also prevents the ocular surface contents to go inside the interior chamber, thereby reducing the risk of endophthalmitis to a larger extent, which is also a nightmare for every surgeon. In view of these benefits, every surgeon aims for a watertight wound closure at the end of surgery. I will be presenting 3 hydration techniques. First one is conventional stromal hydration, second one is anterior stromal pocket hydration, and the third one is hydration using a 30-gauge needle. This study was conducted at the High Hospital and Research Center, Jaipur. It was a prospective randomized comparative study. All the patients were divided into 3 groups with 20 patients in each group according to the type of hydration technique patients underwent. In group 1, I have included patients who have undergone conventional hydration technique, which is done by using a 27-rose cannula. In this technique, we'll hydrate the main incision by hydrating the lateral walls and the roof of the internal stromal tunnel. In group 2, patients underwent hydration using an anterior stromal pocket hydration. In this technique, we made an anterior stromal pocket just supraincisional to the main incision of the clear corneal incision, and further we hydrate that pocket using a cannula until the visible stromal corneal whitening is seen. In group 3, we have included the patients who have undergone hydration using a 30 gauge needle, which is attached to a 2 ml syringe containing a balanced salt solution, and whose wound was hydrated by burying needle into the corneal stroma, which is done just beyond the entry of the clear corneal incision. Now I will be showing a video showing the anterior stromal pocket hydration. In this video, we have created a pocket just supraincisional to the main corneal, clear corneal incision. The pocket is approximately 0.75 to 1 mm in size. This is the creation of the main clear corneal incision, and further we have hydrated the pocket using the cannula until the visible whitening of the cornea. Now in this further video, I have shown the hydration using a 30 gauge needle containing a balanced salt solution. After the completion of the phacoemulsification of the nucleus as well as intraocular lens insertion, we are doing the hydration using a 30 gauge needle, just burying the needle into the corneal stroma in the main wound and the side ports until the visible whitening of the cornea. This needle is inserted just beyond the internal entry of the clear corneal incision. As we can see, the visible whitening of the cornea after the hydration of the wounds. And anterior chamber is formed there. Now in this further video, we will be checking the wound leak post-hydration, and the leak was checked by just pressing the posterior lip of the wound with the help of a cotton bud, and we can see that there was no leak after the hydration of the wound. Now, I have categorized the result in a tabular form for MPs. On the basis of number of times we have to do the hydration, on the basis of leakage due to pressure on posterior lip of wound, and on the basis of post-op wound leak. In group 1, which is conventional stromal hydration, we have to hydrate thrice in 25% of the cases and twice in 50% of the cases. In group 2, which is anterior stromal pocket hydration, we had to hydrate twice in 30% of the cases. And in group 3, which is hydration using a 30 gauge needle, we had to hydrate just twice in 5% of the cases. And as we come to the leakage due to the pressure on posterior lip of wound, leakage was just seen in group 1, which is conventional stromal hydration, that too in just 3 cases, which is 15%. And post-operative wound leak was not seen in any of the group. So after the following study, we came to conclusion that hydration with the 30 gauge needle is very useful sutureless technique, especially in young and pediatric patients, as collagen fibrils are very elastic in these patients, to seal leaking phacoemulsification wound in a single attempt, and also to avoid complications related to post-operative wound leak and excessive wound hydration. Thank you so much.
Thank you. Please collect your certificate, Dr. Monica.
Surgery. Rapid cataract formation is typically a result of lens capsule rupture with seepage of aqueous humor into the lens fibers, the prevalence being 65%. Mechanism of injury should be determined, and if intraocular foreign body is suspected, then additional imaging is required. It is important to determine whether the injury was penetrating or blunt in order to decide whether additional imaging is needed and to plan surgery.
It is important to characterize the location of the lens opacity. Classically, traumatic cataracts have a rosette or stellate appearance. Presence of phacogenesis and anterior capsule rupture should be looked for, as these features confirm whether there is zonal injury and determine the urgency of performing cataract surgery. B-scan is obtained if the posterior segment is not visible. B-scan will confirm the glow contour, the intraocular foreign body, vitreous opacities, retinal detachment, and choroidal rupture. Materials and methods used. This is a prospective hospital-based study which was performed in a tertiary care center from January 2023 to August 2023. Study design being prospective analytical study. 21 cases presenting with traumatic cataract who underwent cataract surgery were included in the study. Detailed history was taken and a slit lamp examination was done. Preoperative vision was recorded, and for posterior segment we did indirect ophthalmoscopy. In case of suspected intraocular foreign body, X-ray orbit was done. B-scan was done in cases where the posterior segment was not visible. After cataract surgery, which included phacoemulsification and manual small incision cataract surgery, post-operative vision was recorded and compared with the pre-operative visual acuity. The data collected was analyzed statistically by SPSS software version 23. Percentages and proportions for qualitative data, student t-test for quantitative data, and for association, mean and standard deviations were used. Other statistically appropriate parametric and non-parametric tests were used wherever they were needed. Results: 21 patients presented with traumatic cataract and underwent cataract surgery with mean age of presentation of 27.86 years. Youngest was 5 years and the oldest patient was 75 years. Males corresponded to 16 cases were more predisposed than females. Wooden stick was the most common object causing injury in 33.33% cases in this study. Penetrating injury was the most common cause of traumatic cataract in 52.4% cases, followed by blunt trauma in 38% cases, whereas electric shock was rarely seen in 9.52% of cases. 14.2% of patients presented with visual acuity of 6/60 preoperatively. 38.02% of cases had only perception of light and projection of rays. 19% of cases attained post-op visual acuity as 6/12. Statistically significant improvement with p-value of 0.042 was recorded on comparing the pre-op and post-op vision using Spearman's coefficient of correlation test. 13 cases underwent small incision cataract surgery, whereas in one case phacoemulsification was done. SICS plus corneal tear repair was done in 5 cases, and phacoemulsification with corneal tear repair was done in 2 cases. 7 cases presented with corneal tear along with traumatic cataract. In all of these cases, the mode of injury was documented as penetrating trauma. Retinal detachment was detected on B-scan in 9.5% of cases, whereas vitreous hemorrhage was seen in 4.76% of cases. Discussion: ocular trauma can occur by many mechanisms which can affect the crystalline lens. The mode of injury includes penetrating, blunt trauma, electric shock, ultraviolet, ionizing radiations, and chemical injuries. Depending on the nature and extent of ocular trauma, opacification of the lens may occur immediately or years after an injury. In our study, 76.2% of cases were males. Srivastava et al. Also found in their study that males are more affected. Males are predisposed to ocular injuries because of more involvement in outdoor activities. 42.85% of cases were from pediatric age group between 5 to 15 years. Sethi et al. Also reported that most of the patients were young and half of them were children. Bowman et al. Reported similar findings. Trauma is the leading cause of 90% of acquired pediatric cataracts. 52.4% of cases suffered penetrating injury in our study. Penetrating injuries are the most common cause of ocular injuries. In our study, the most common object causing injury was wooden stick, which is very similar to the study of Memon et al. Corneal tear was the most common associated finding, which was seen in 33% of cases. Intraocular lens implantation was successfully done in 95.23% cases in our study, similar to the study of Goget P. et al. 28.5% of cases attained post-operative visual acuity of 6/18 or better in our study. Again, et al. Concluded that most of vision depended on complications, which holds true for our study as well, because 52.38% of cases who had corneal scarring did not attain good visual acuity, and p-value was not significant of 0.364. In 14.28% of our cases, posterior segment pathology, including retinal detachment, vitreous hemorrhage was present and had poor post-op visual outcome. Sophia et al. Stated that type of trauma, penetrating or blunt, had no significant effect on final visual outcome. In our study, the improvement in visual acuity in patients with penetrating or blunt trauma was not statistically significant. Conclusion: penetrating injury is the most common mode of injury in traumatic cataract. Males are at a higher risk. Traumatic cataract associated with corneal scarring, which obscures the visual axis, or any posterior segment pathology, have poor post-operative visual acuity. The references are these. Thank you.
Before that, did you do the ocular trauma studies Korean diagram? You are not mentioned. Secondly, what kind of lenses were recommended? Because in these traumatic cases, maybe it was not possible for you to go in the bag.
Yes.
So what was
strategy? After 21 cases in our plan, 19 cases PCIO was started, in 2 cases ACIO.
that should also have been mentioned. Coming to certificate. Dr. Silika is here. Dr. Vijay Mangawa. Silika.
Good morning everyone. I'm presenting my paper on the topic evaluating the effect of addition of eye drop loteprednol to the standard treatment regime in managing severe viral conjunctivitis, a comparative study. Conjunctivitis, often referred to as pink eye, is a common ocular ailment characterized by the inflammation of conjunctiva. The most common cause is viral, that accounts for up to 75% of all the cases. Amongst the viruses, the most frequent being the adenovirus. Generally, it is a self-limiting condition, but severe cases need effective management. The clinical manifestation of viral conjunctivitis encompasses a spectrum of severity, generally categorized into mild, moderate, and severe. Mild cases usually present with slight redness, watery discharge, minor discomfort, often resolving without medical intervention within a week or 2. Moderate cases may exhibit more pronounced symptoms that may require medical attention to alleviate the discomfort and prevent the secondary bacterial infection. Severe viral conjunctivitis, that is the focal point of this study, is demarcated by the presence of complications like chemosis, eyelid swelling, coupled with persistent and debilitating symptoms such as pronounced itching, excessive tearing, and significant discomfort. Aim and objective: to evaluate the effect of addition of a soft steroid, that is eye drop loteprednol, to the treatment of severe viral conjunctivitis, to evaluate the time taken to provide symptomatic relief in a group with additional soft steroid versus the group with conventional treatment. It was a prospective comparative type of study, observational study. All patients having severe viral conjunctivitis were taken. Sample size was calculated as 25 patients in each group A and B. Study time was July to August. This study enrolled a total of 50 patients diagnosed with severe viral conjunctivitis, equally distributing them into 2 distinct groups, which were then randomized alternatively. Group A was given eye drop moxifloxacin 4 times a day, eye drop CMC 6 times a day, cold compressions with painkillers SOS, and Group B was given the same treatment with additional loteprednol 4 times daily for a week, followed by tapering. Clinical evaluation, the following were recorded: the visual acuity, intraocular pressure, corneal fluorescence staining. Inclusion criteria was all patients having severe viral conjunctivitis with eyelid swelling, chemosis, and significant discomfort. Exclusion criteria was patients lost to follow-up, mild to moderate conjunctivitis cases, glaucoma, history of rise in IOP following topical steroids, dry eyes, corneal staining including dendritic ulceration. All patients attending the IOPD were taking. All patients having severe viral conjunctivitis. Inclusion and exclusion criteria was applied. Systematic random sampling was done, and the patients were divided into group
group A and B, and they were followed up every 3 days, and symptomatic relief was analyzed and statistical analysis was done. Results were, the total number of patients were 50, 25 patients in each group. Mean age of the patients in group A was 26.4 plus minus 10.2 years. Mean age of patients in group B was 25.7 years plus minus 9.7 years. There were 11 males and 14 females in group A, and there were like 13 males and 12 females in group B. The mean time for symptom relief was 2.8 days plus minus 1.8 days in group B, as opposed to 8.2 days plus minus 2.1 days in group A. The mean time for eyelid swelling reduction was 3.2 days in group B, as opposed to 9.1 days in group A. These were the results. So as we can see, the group B provided the symptom relief earlier than the group A. Conclusion, the findings delineate that the adjunctive use of hydrochlorothiazide in the therapeutic regime potentiates a substantial enhancement in managing severe viral conjunctivitis. This addition fosters better patient outcome, underscored by superior symptom relief and enhanced patient comfort and well-being. Thank you. These are the references.
Thank you. Did you do any other tests to confirm that this is viral or bacterial?
So the fluorescent staining was
clinical.
Mainly clinical with fluorescent stain and like slit lamp.
No clinical swab was taken.
No sir, swab was not taken, it was mainly clinical.
Because without that you cannot say this is viral. But staining was always done. Fluorescent staining.
So if there was staining or if there was any epithelial defect, then those patients were excluded from the study.
That was not mentioned.
So it was mentioned in the exclusion criteria.
Is separate particular or combination of drops? What is frequency of the drop, and you use separate or combination of the moxifloxacin and dolutegravir?
So separately, and the frequency was like QID for 1 week, and then it was tapered like TDS and BD and then OD.
Follow up the patient for the recurrence of the...
So there was no recurrence.
100%.
Yeah. So it was like 1 month follow up, so there was no recurrence.
1 month follow up.
Yeah, like there was no recurrence in that 1 month period.
Not easily conjunctive patient 1 month period of
All patients, you mean all patients did turn up after 1 month, up to 1 month?
No, sir, not all patients. The lost to follow patients were excluded from the study.
All those patients who were included in this study, they all turned up to 1 month.
Yes, sir.
Thank you. Collect your certificate. Dr. Vijay Singh Rungava.
Good morning, respected teachers and my colleagues. I am presenting my paper on association of serum vitamin D level in dry eye patient under the guidance of Dr. J. Murli Manohar sir, Anil Chauhan sir, and Dr. Dekal. Let's start with the introduction. Visual impairment, especially in developing countries, was global challenge with increase with the age. The primary cause of blindness and visual impairment comprise uncorrected refractive error, cataract, age-related macular degeneration, glaucoma, and diabetic retinopathy. The role of vitamin D, as we all know, vitamin D is a fat-soluble vitamin, multifunctional and molecule which produced in the skin on the exposure to sunlight. There are two main forms of vitamin D, D2 and D3, which is known as ergocalciferol and cholecalciferol respectively. It regulates calcium homeostasis. It also aids against oxidative stress, inflammation, autoimmune disease. Its important role has been documented in various ocular pathologies like dry eye, uveitis, glaucoma, ARMD, myopia, and diabetic retinopathy. Hence, vitamin D helps in the suppressing oxidative stress. This leads us to investigate in the association of vitamin D in dry eye patients. Therefore, finding of modifiable risk factor which can reduce or halt the progression of the disease can prove to be cost effective. Material and method. It was a cross-sectional prospective study conducted over a period of 1 year. It includes 63 patients with dry eye. Detailed physical, systemic and ophthalmic examination were performed and analyzed later. The result, the demographic data, total case was 63, mean age 64.02 year, male was 27, female was 36, mean height 1.65 meter, mean weight 63.98 kg, mean BMI was 23.45 kg per meter square. The habitual characteristic, we can choose smoking and alcoholism as a habitual characteristic. Majority of cases neither alcoholic nor smoker. Few were in the past and the present with the history of alcoholic and smoking. The assessment of vitamin D. The serum vitamin D level less than 10 nanogram per ml found in 19 cases with a percent of 30%. The 10 to 20 nanogram per ml found in 23 cases with a percentage of 36. 20 to 30 nanogram per ml found in 17 cases with the percentage of 27%. Only 4 cases found with the more than 30 nanogram per ml, which is 7% in our study population. The mean serum vitamin D level is 16.7 nanogram per ml. The minimum with the minimum value 5.59 nanogram per ml, maximum value 38.2 nanogram per ml. Mean serum vitamin D level in male was 18.88 nanogram per ml with minimum of 7.3 nanogram per ml and maximum of 38.2 nanogram per ml. Mean serum vitamin D level in female was 14.96 milligram per ml with minimum 5.59 nanogram per ml and maximum 36.36 nanogram per ml. It also associated, the cataract is also associated with the dry eye. Total case 63, in which 44 with the cataract and 19 without cataract. In cataract group, 16 with the nuclear cataract, 14 with cortical cataract, and 7 with the posterior subcapsular, and 4 with the mixed cataract, and 3 with the anterior subcapsular cataract. In dry eye statistics, TBUT score, the mean TBUT score 8.48 in overall population. With the cataract, it was 8.36, and non-cataract patient, it was 8.76. And with the CMAT test, the mean was 10.3 in overall population. With the cataract, it was 10.13, and with the without the cataract, it was 10.95. So the association of dry eye with lesser in the non-cataract patient. Discussion from my study. Mean age of the dry eye patient was 64 years, male-female ratio being 27:36. Mean serum vitamin D level was 16.7 nanogram per ml. Low serum vitamin D also have higher association with the dry eye disease. Conclusion. Aim of this study was to understand the role of serum vitamin D in dry eye patients. Vitamin D play a significant and valuable role in the development of dry eye. This aid to start evaluating vitamin D in level of or routine checkup. Hence, more studies should be conducted in order to assess role of vitamin D in various ocular pathologies as well.
Please correct your certificate. Dr. Rucha Pathare.
Good morning, one and all. Topic of my presentation is comparison of endothelial cell loss and cornea thickness changes following manual small incision cataract surgery and phacoemulsification. Introduction. Blindness is a severe debilitating condition to the mankind. Nearly 36 million people are blind all over the world due to various causes. Cataract and uncorrected refractive errors are the most common cause of blindness and severe visual impairment. In India, blindness is around 12 million, of which also cataract is leading cause of preventable blindness, that is around 7.75 million. Cataract surgery is one of the most frequently performed surgeries throughout the world. In India, around 5 million cataract surgeries are performed annually. Manual small incision cataract surgery and phacoemulsification are the preferred techniques for performing cataract surgeries. Corneal endothelial cell loss remains a well-known undesirable side effect of cataract surgery that may, in severe cases, negatively impact patients' post-operative visual outcomes. Aim of my study is to study the corneal endothelial cell count and central corneal thickness in pre-operative and post-operative MSICs and phacoemulsification. Objectives were to analyze the central corneal thickness changes in pre-operative and post-operative patients of MSICs versus phacoemulsification. And second was to analyze the data and compare the endothelial cell count change before and after the MSICs and phacoemulsification. Inclusion criteria were age 40 to 80 years, sex, both sexes were selected. Patients diagnosed with age-related cortical or nuclear cataract and scheduled for cataract surgery were selected. Exclusion criteria: subjects with active eye disease, history of serious eye injury, history prior to eye surgeries, known cases of diabetes, and other cause of decreased vision such as glaucoma, retinal pathology, or pseudoexcitation were excluded. Also, a pre-operative endothelial cell count of less than 2,000 cells per millimeter square. Intraoperative conversion of surgical technique from phacoemulsification to MSICs. Intraoperative posterior capsular rupture with vitreous loss, and those unable or unwilling to provide the informed consent. Those who are not willing for follow-up were excluded from the study. Methodology: patients visiting NIMS ophthalmology OPD for cataract surgery were selected. Detailed history was obtained regarding systemic and ocular conditions. Patients were then selected based on inclusion and exclusion criteria. Informed consent was taken. Patient operated by a single surgeon with a fixed technique was selected. Pre-operative and post-operative first, third, and sixth week corneal endothelial parameters were noted. First, the final data was compared with each other, and statistical analysis was done and results were obtained. This is a specular microscope I used. Observation: these are the results. These are the comparison between two groups for central corneal thickness. These are endothelial cell density comparison between the two groups, phacoemulsification and MSICs. These are the comparison of endothelial cell parameters in pre-operative with third and seventh week post-operative in MSIC group. And these are the comparison of endothelial cell parameters in pre-operative with third and sixth week post-operative in phacoemulsification. Conclusion of my study was, our study was has shown that there is a greater increase in CCT in phacoemulsification compared to MSIC surgeries. The study also showed that there is a significant percentage of cell loss in phacoemulsification as compared to MSIC surgeries. And the study demonstrated that phacoemulsification is slightly superior to MSICs, but the results of my study were not significant, statistically significant. These were the references. Thank you.
Thank you. Please collect yourself. The next presenter is Dr. Sapna Gupta.
Good morning everyone. I am presenting my paper on the topic changes in corneal topography after frontale suspension surgery in patients with congenital ptosis. Congenital ptosis is defined as drooping of the upper eyelid since birth or within 1 year of age.
The eyelid pressure causes flattening of the peripheral cornea and steepening of the central cornea, which leads to higher incidence of corneal astigmatism and loss of symmetry. Corneal topography of ptotic eye also shows more surface irregularity and asymmetry as compared to normal eye. Various theories propose that upper eyelid cause a band-like pressure on the cornea. This may cause with-the-rule astigmatism due to altered corneal shape. The aim of the study was to evaluate changes in corneal topography after frontalis suspension surgery in patients with congenital ptosis. Objectives were to measure pre-operative corneal topography parameters and compare them with the post-operative values at 6 weeks and 12 weeks, and to record best corrected visual acuity and study changes in the long term. Material and method. The study design was descriptive observational type. Sample size was 37 cases. Study was done from January 2023 to August 2023. Patients' preoperative corneal parameters were noted by Steinfeld corneal topography. Then frontalis sling surgery was done using silicone sling with Fox Pantarin technique. Corneal topography was done again at 6 and 12 weeks follow-up period. Inclusion criteria: patients who are willing to give informed consent to surgery were included, and patients above 5 years of age diagnosed as congenital severe ptosis. Exclusion criteria: other causes of ptosis like mechanical, neurological, and traumatic ptosis, any corneal abnormality due to BKC or dry eye, previous surgery or previous trauma. Observation and the results. The mean age of patients were 12.48 years. Among 37 patients, 21 were males and 16 were females. CPAS K was declined post-operatively, and because the p-value is less than 0.05, it was significant. Superior K and inferior K was also decreased post-operatively, but the decrease in inferior K was significant. SIN-K max and SIN-K minimum were decreased, but they were not significant. CCT was also not significant post-operatively. Surface regularity index at 3 mm and 5 mm was also insignificant. Results: surgical ptosis repair resulted in a significant decrease of CPAS K, indicating flattening. Both superior K and inferior K decreased after surgery, but the decrease in inferior K was statistically insignificant. This indicates that surgery resulted in the global flattening of cornea, but more in the inferior hemisphere. Other corneal topography parameters like SIN-K max, SIN-K minimum, CCT, and surface regularity index were also compared, but there was no significant difference. The post-operative changes in best-corrected visual acuity, cycloplegic sphere, and cylinder were also minimal. Conclusion: ptosis correction surgery resulted in significant flattening and regression of anterior corneal surface to near normal anatomy. This further resulted in improvement of corneal surface regularity and symmetry. Thank you.
Thank you. So, what do you think is the cause in the change of corneal topography because of ptosis surgery? Why does it change?
Because of reduction in the eyelid pressure, which was causing initially steepening of the central cornea.
But you said that there is no change in the refraction, there is no change in hearing.
So there was no change, no significant change in visual acuity and refraction post-operatively.
If the refraction doesn't change, why does the shape of the cornea change? And because they are correlated,
Yes,
connected to each other. How do you explain that?
So there were changes in refraction, but that was not significant, and changes in CPAS K was significant. The CPAS K was kept. Yes, sir.
What was the material for the sling?
So silicone sling.
Silicone sling. All patient?
Yes, sir.
Thank you.
Correct, sir. Please. The next speaker is Dr. Rishabh Gupta. Is he here?
Good morning all. My topic is intraocular pressure changes in patients with IOL implantation assisted with balance or solution and ophthalmic viscosurgical devices in phacoemulsification surgery. The introduction. Ophthalmic viscosurgical devices or viscoelastic agents play an important role in the development of new approaches to the phacoemulsification. The surgical benefits of the OVDs are the protection of the corneal endothelium, maintenance of the anterior chamber, and assistance with the implantation of the intraocular lens. However, in addition to these benefits, OVD may also cause spike in the postoperative intraocular pressure. If the OVD behind the IOL is not completely removed, it may lead to the capsular distension syndrome. To prevent this complication, careful OVD removal should be performed, though this may prolong the surgical time, which may be associated with the further endothelial cell loss. To avoid these complications, a technique has been described in the literature of IOL implantation using a balanced solution to maintain the anterior chamber rather than filling with the OVD. Now, aims and objectives. The aim to study the intraocular pressure changes in the endothelial cell count in the balanced solution and the ophthalmic viscosurgical devices assisted intraocular lens implantation in the phacoemulsification surgery. Objectives: to measure the pre-operative intraocular pressure and compare them with the post-operative values at day 1, week 1 and after 1 month. And to measure the pre-operative cornea endothelial cell count, the hexagonality, the coefficient of variation and compare them with the post-operative values at the 6 weeks. And to record the UCVA and the best corrected visual acuity and study the changes in the long term. The material and the methods. The study design, a hospital-based comparative interventions type of study. Sample size, 90 cases were there with 45 in the BSS group and 45 in the OVD group. Study time was from 1st December 2022 to 31st August 2023. The methods. For an OVD group, the routine phacoemulsification steps were followed. But for the BSS group, after doing the irrigation and aspiration steps for the complete removal of the cortex, no OVD was injected in the eye. As you can see in the photos, first there is the irrigation cannula of the bimanual IA probes is capped in the eye and the incision is enlarged to desired size with a 2.2 gradome. And the second image you can see the PCL is loaded with the balanced solution, not with the viscosurgical device, and is put in the cartridge and with the sufficient lubrication of the IOL. The third photo is to implant the IOL. The irrigation cannula of the bimanual IA probe is kept on the continuous irrigation mode so that the AC is maintained continuously. And the IOL is gradually injected into the eye and leading to the haptic and the optic of the IOL are inserted into the capsular bag. This technique was shown by the Harshvardhan sir, and all the incisions were sealed with the corneal stromal hydration and was checked for the leakage with the microsponge. Follow-up visits will be done at post-op day 1, 1 week and 1 month. The inclusion criteria were patients who are willing to give their consent, no other ocular pathology, pupil dilation greater than 7 mm, senile nuclear cataract grading up to 2, according to the lens opacification classification system. The exclusion criteria were more that there will be excluded the uncooperative patient, compromised endothelial cell function, corneal ectasia, any corneal dystrophies, corneal opacities, any diabetic patient, any complication during the time of surgery, any glaucoma patient or pre-operative intraocular pressure more than 25 mmHg, the shallow anterior chamber, subluxated lens, zonal dialysis, previous history of any trauma and previous history of any ocular surgery. The results were there. The comparison of age and sex were non-significant as both the male and female were equally in the BSS and the OVD group. There was significant changes in the pre-operative and the post-operative IOP of the BSS and OVD. In the balanced solution, the post-op day 1 IOP was significantly lower than the post-op IOP of the day 1 of the ophthalmic viscosurgical devices group. As you can see in the BSS group, it was 15.1 with the standard deviation of 1.56. In the OVD group, it was 18.13 with a standard deviation of 2.01. And the post of 1 week was also found to be significant, but it was slightly significant, not at higher values. And post of 1 month, both the groups, there were similar results. The endothelial cell count were decreased in both the groups, but there was no significant changes in the post of 6 weeks. The coefficient of variation and hexagonality were also compared. The coefficient of variation increased in both the groups after the phacoemulsification surgery and hexagonality decreased, but there was no significant changes. As with the uncorrected visual acuity and the best corrected visual acuity, after 6 weeks, both the results were same. Conclusion. IOL implantation using a basal salt solution phacoemulsification surgery is a reliable technique, and this method has significantly shorter surgery time and a much smaller post-operative IOP increase. There is no need of OVD removal from behind the IOL and no risk of early capsular bag syndrome. The reduced IOP increase after the cataract surgery might be particularly helpful for the glaucoma patients. Thank you.
Thank you. So why don't you, there are many people who are doing without any OVD. But what do you think, why do people use OVD then?
So to maintain the anterior chamber and to facilitate the IOL implantation.
even for doing Rexis.
Yes, sir.
Using, so you have not used in the group cases group, you have not used.
No, sir. At the time of IOL implantation, we have not used. At the time of access, there was use of the OD.
Thank you. Please correct your certificate. The next presenter is Dr. Sahil Jain.
Good morning, I'm Dr. Sahil Jain. I'm here to present my paper. It's a comparative study of the changes in the corneal astigmatism and also on the corneal aberration. And I'm comparing it between a 2 mm and a 2.4 mm and a 3 mm opposite clear corneal incision during phacoemulsification with IOL surgery. So, doctor, will I be able to see clearly after the surgery? Is a very quintessential question that every cataract patient asks their doctor. To which the doctor explains certain things. And a common thread there is आंखों की रोशनी लेंस पर्दे वगैरह पर निर्भर करती है. And now, so in that given case, when the parda or the hira, that is the cornea and the retina is normal, then by just replacing the cataractous lens, we can correct the vision. But then what will hamper the vision are the refractive errors, which are the myopia, hyperopia, and astigmatism. While the former two can be corrected by the IOL, the latter, that is the astigmatism, is what still remains after the cataract surgery. So what I'm trying to imply is that cataract surgery is the most powerful refractive procedure. It can correct anything from -30 diopter of myopia to +20 diopter of hyperopia to a plano. But it still has some limitations, that its inability to rectify the pre-existing astigmatism, its limitation to a unifocal vision, and also corneal abrasions. While corneal abrasions are still a surgical anomaly that we cannot correct, complication, and unifocal vision can be corrected with presbyopic IOL. What we are here to talk about is intraoperative correction of the pre-existing astigmatism, and how we can do that. There are like 3 alternatives. First is the toric IOL, which is the most favored in developing countries, as it can correct higher powers of astigmatism. But in countries like developing countries like ours, it remains as an expensive alternative, and also due to its misalignment, it can be highly unpredictable in its impact on the vision. Then the second is the limbal relaxing incisions. This also is a rather skilled job, and it highly depends on the surgeon's experience and also on the healing properties of the cornea. So then comes a third alternative, which is opposite clear corneal incision, which are rather simple to perform, inexpensive, no extra time requiring procedure, that where we just give 2 opposite clear corneal incisions along the steepest axis, and it produces a stable flattening effect, as has been observed over the long time. How it acts is basically, if I have to tell about the mechanism, like if with the corneal suture we pull the cornea together, we pull the corneal tissue and we make it taut, so the cornea becomes steeper. Similarly, when we give an incision, the cornea will be the tension would be released and it will become relatively flatter, and that would lead to flattening of the steepened axis. So my aim was to compare the changes in the astigmatism between the 2.4 and 3 mm corneal incisions, and I did so by doing a pre-operative and post-operative workup using shine fluid imaging via the Sirius topographer in our department, and I basically followed with 3 parameters: axis and the power of the cylinder, the higher order aberrations, UCVA and BCVA. It was a prospective interventional study. My sample size was 80 eyes, which I randomly divided into 40 eyes with 2.4 mm and 40 eyes with 3 mm OCCI, and it was conducted over a period of 8 months. I included basically against the rule astigmatism patients with 1 to 2 diopter of astigmatism, and I excluded any other patient with any pre-existing corneal or lenticular opacity or any other refractive surgery. My method after basically doing the surgical procedure was, first I marked the steep axis using the Whitman's axis marker. This particular patient had 1.22 diopter of astigmatism at the 11 degree axis. So first we created the main port with either a 2.2 or 2.8 keratome depending on the group, if it was a 2.4 or 3 mm group patient respectively. Then after the main port, just opposite to it, I created a second opposite clear corneal port, and then I left it patent. The surgeon left it patent basically. Then the surgery was performed through the main port, and in the end, firstly the main port was hydrated and sealed, and then afterwards the opposite paired port was sealed. And then the results that were obtained were of the 80 patients, the mean age of the patients was 66.02 plus minus 17.85 years. Age, sex, preoperative UCVA and corneal astigmatism showed no significant difference. And what was then observed in the results was, while the mean pre-existing corneal astigmatism in the 2.4 and 3 mm groups were 1.56 and 1.63 diopter respectively, compared with the post-operative astigmatism in 3 months, the values were 1.17 and 1.01 diopter respectively. So they basically showed a mean reduction of 0.39 and 0.62 diopters respectively, while the higher order abrasions which were compared were at the 5 mm area were not significantly different. And also the mean UCVA at 3 months showed a significant difference, where the 2.4 mm group showed 0.19 value logmar UCVA, while the 3 mm group showed 0.1. And while the BCVA showed in the 2.4 mm was 0.08, and in the 3 mm group it was 0.05. So what we would like to say is that as we are heading towards modernizing our surgeries, the modern cataract surgery is now using smaller incision, foldable IOLs, and also various means to correct the astigmatism, basically to achieve a post-operative emetropia, because that's what the patient asks. Patient wants to undergo cataract surgery and expects a clear vision, and reduction of corneal astigmatism is very important. And the 3 mm OCCI showed a higher reduction in PEA, and it did so without increasing the higher order corneal abrasions, especially compared to if we compared it with the single corneal incisions. And also it did not show any increased risk of post-operative endophthalmitis based on the previous studies. So in the end, I would just like to conclude that opposite clear corneal incisions are effective to reduce mild to moderate pre-existing astigmatism without increasing corneal abrasions. Personalized treatment selection remain an option for visual outcomes in cataract surgery. Thank you.
Thank you. So, are there any larger studies done, or you?
Yes, sir. There have been larger studies conducted elsewhere with
what are the number of cases there?
Sir, 180 sample size. So my seed article had a sample size of 180, and then there have been newer studies conducted where the sample size has been further higher up in the range of 250 and so. And yes, sir.
So you want to conclude that you can reduce the astigmatism by 0.4 to 0.5
yes, sir.
diopters.
Yes, sir.
But what about the residual then?
So basically, I would say, sir, basically I put this in the context of a developing economic condition, where and also, sir, I see it for the benefit and what all it requires. It requires no additional time, no cost, same keratome, same sitting, and then there is the cost effectiveness. And obviously, I would prefer anything that takes patient towards a more emetropic and post-operative clear spectacle-free vision.
Thank you.
Yes, sir. Thank you.
Correct your certificate. The next speaker is Dr. Vivek Goyal. Is Dr. Deepika here? So we'll take that in the end.
Good morning, everyone. I am here to present my paper on complication in pterygium excision with conjunctival autograph, a comprehensive review.
As you all know, pterygium word derived from Greek word pterygium, which means wing. So pterygium is a wing-shaped land growth on the ice surface, which is common in northwest India due to hot climate, leading to discomfort and visual issues. As we all know, that Rajasthan lies 30 degrees north and south to the pterygium belt lies 30 degrees north and south to the equator, and Tropic of Cancer passes through the Rajasthan. So Rajasthan comes in the north in pterygium belt. So pterygium very common in Rajasthan. Its treatment in surgery with congenital autograft is gold standard, and low recurrence, fewer complication is noted in the congenital autograft compared to other medicine methods like Weck technique. The challenges, despite the advances, are complication can affect patient outcomes like visual outcomes and patient's satisfaction. The study design was prospective, interventional, longitudinal and hospital-based study, which was done at SP Medical College in Associate Group of Hospital, Bikaner, between 2020 to 2023. Patient with less than 6 months of follow-up and patient who were not willing to give consent for the study were excluded, while inclusion criteria were patient diagnosed and treated with conjunctival autograft for primary pterygium, conjunctival limbal autografting for recurrent pterygium, and vertical split autografting for double-headed pterygium, primary. Total 650 eyes in 620 patients were included. Out of those, 630 patients had primary pterygium, 576 eyes had single-headed pterygium, 54 cases had double-headed pterygium, and 20 cases had recurrent pterygium. 590 patients had unilateral pterygium, and 30 patients had bilateral pterygium. Pre-operative data collection, demographic information such as age and sex recorded, visual acuity was assessed. Ocular examination including measurement K1 and K2 was done, surgical history was taken. While in post-operative data collection, recorded the type of surgical procedure was recorded, assessed visual acuity was recorded, complication was monitored, and documentation for the duration of follow-up as per study protocol was recorded. The follow-up period extended from 6 months to 18 months, and on average patient were followed approximately 11 months. Here are results. Common complication observed during pterygium surgery and conjunctival autografting was subconscious hemorrhage, which amounts to 38.8%, followed by graft edema, which lies 21.8%. Then graft retraction and graft loss, graft bleeding, and recurrent pterygium, which is 0.15%. Here are a few points to note that no corneal merit and perversion was noted in our series. Granuloma formation and tenant cyst were seen in one patient but resolved with topical steroids. Minor complications resolved spontaneously while antibiotic steroid treatment. In total 650 patients of total cases, 252% had complication of subconjunctival hemorrhage, while 142 had graft edema. Out of 650 patients, 630 had primary pterygium. On those, 244 had complication of subconjunctival hemorrhage, while in recurrent pterygium, only 8% out of 20, which lies 40%, had subconjunctival hemorrhage. Here is the graphical representation of total pterygium, which is stated 38.8%, which is 252 patients. Out of 650 patients had subconjunctival hemorrhage, while the minimum patients were noted with tenant cyst and granuloma, which was 1%. In primary pterygium, which is a 630 patient, which is out of 650 patients, which is almost 96%. So results of total pterygium are comparable to the results of primary pterygium, which is almost same. In recurrent pterygium, maximum patient was noted with the subconscious hemorrhage, while minimum one patient was noted with recurrence. Here are some pictures showing the complications. In discussion, in our series, subconscious hemorrhage and graft edema were victimized as the most frequent complication, while tenant cyst and granuloma formation at donor site was reported as least frequent complications, which are similar to a study profile of complication in pterygium study, a retrospective surgery, a retrospective analysis conducted by Shrishla K. Co-author. Pterygium extensor conjunctival autograft remains a highly effective treatment for pterygium with low recurrence, 0.15%. Results are similar to a study conjunctival autograft for pterygium done by Elizabeth Fairfield, and a study profile of complication pterygium study, a retrospective analysis conducted by Srisha K. Co-author. A study outcome of pterygium surgery, analysis of over 14 years conducted by Cornea and Anterior Segment Service, LV Prasad Eyes Institute, Hyderabad, India, states that CAG appears to be an effective modality for primary and recurrent pterygia, which is similar to our analysis states. In contrast to study profile of complication in pterygium surgery, a retrospective analysis conducted by Srisha K. Godavar, complication like corneal milk and skilled professional was not recorded in our study. Conclusion. Pterygium excision with conjunctival autograft stents is a high effective treatment for pterygium. Complication understanding and management are paramount for optimizing patient outcomes. This study sheds lights on the complications related to this procedure and provides guidance for reducing their incidence and managing them effectively. Enhanced knowledge in this domain promises increased safety and success in pterygium excision with conjunctival autograft. Here are the references. Thank you.
Thank you. Congratulate you for the large study, large number of cases you have done. One question, you have not mentioned about exclusion criteria.
Sorry, sir.
You have not mentioned about exclusion criteria.
Yes, I mentioned. Patient less than 6 months of follow-up period and patient who don't ready to give their consent were excluded.
But otherwise, there was no, from your side also, there was no exclusion for any kind of surgery, whether it was recurrent or bilateral or.
Sir, in total 650 cases, primary pterygium and recurrent both are included, and complications are compared in all the series.
Good. Thank you. Next is Dr. Sarajbir Singh Pannu.
Good morning, everyone. So today I'm going to present the topic of analysis of post-operative intraocular pathologies in patients with mature cataracts. So a mature cataract is, whether it's white or luminescent, is completely opaque lens that leads to severe vision impairment. Due to heightened complexity of the surgery and associated with risk factors, prior studies have primarily concentrated on safe surgical techniques for mature cataracts. In addition to surgical considerations, mature cataracts pose significant challenges in pre-operative assessment phase. This is because the severe opaqueness of the media obstructs the view of the back portion of the eye, while the B-scan ultrasonography serves as a pre-operative diagnostic tool for identifying rough intraocular abnormalities like posterior staphyloma, retinal detachment, and vitreous hemorrhage. It does have its limitations though. There are also available pre-operative assessment techniques utilizing visual electrophysiology, but their precision and stability are influenced by various factors and their outcomes are confined to forecasting the post-operative visual function. This implies that a precise, comprehensive intraocular examination is only achievable after the removal of cataract in eyes with mature cataracts. Nevertheless, there has been a lack of comprehensive evaluation regarding the occurrence and determining the factors of intraocular pathologies observed subsequent to mature cataract surgery. So the objective of the study is to estimate the prevalence of intraocular pathologies after mature cataract surgery and to determine the risk factors of the intraocular pathologies after mature cataract surgery. So the method, it is a retrospective observational study and was conducted in JNU Hospital, Jaipur. A total of 100 patients were diagnosed with either luminescent or white cataracts who underwent cataract surgery between May 2022 and May 23, who were reviewed retrospectively. Patients whose fundus examination findings and the results within 3 months post-surgery were available were included in the study. Patients with documented posterior segment pathology prior to ocular surgery or penetrating trauma and an age of below 18 years were excluded from the study. In cases where both the eyes met the eligibility criteria, the eye that underwent surgery at a later date was selected, and this decision was made considering that the fundus status of the fellow eye, which is one of the variables in the study, was available after the preceding cataract surgery. The statistical analysis was done using SBS version 25.0. Logistic regression analysis were performed to identify the factors associated with intraocular pathologies. Each variable underwent a univariate analysis and factors with p-value less than 0.20 in the univariate analysis was subjected to a multivariate logistic regression analysis. A p-value less than 0.05 was considered indicated of significance. So the results were a total of 683 patients underwent cataract surgery between May 22 and May 23. Among these cases, 100 patients were selected with luminescent, out of which luminescent was 63 and white cataracts were 37, which met the criteria for the study. All patients underwent cataract emulsification and IOL insertion in the capsular bag, except for 6 patients who underwent additional vitrectomy and scleral fixation of the IOL or surface implantation in the IOL due to posterior capsular rupture. On average, the patients are 63.5 plus minus 8.1 years old, indicating some variability in ages. Gender distribution shows that 58 male and 42 female patients were there. 53 have hypertension, 39 have diabetes, 61 have cataracts affecting their right eye, and an average axial length of 24 plus minus 1.04 mm was there. 22 patients exhibit some form of pathology or condition in their eye, underscoring the importance of comprehensive eye care for these individuals. So, drusen was the most common pathology observed in 6 eyes, followed closely by glaucoma, myopic degeneration, and retinal detachment, each affecting 5 eyes per fever. Diabetic retinopathy is found in 4 eyes, while exudative, age-related macular degeneration, retinal tear, and epiretinal membrane each occur in 2 to 3 eyes. Less frequently observed pathologies were lattice degeneration, geographic atrophy, peripheral chorioretinal atrophy, and retinal pigment epithelium scars. So a univariate analysis showed that the luminescent cataract had a history of diabetes, hypertension, and pathology in the fellow eye were significantly associated with the intraocular pathologies in the mature cataract eyes. However, multivariate analysis revealed that history of diabetes, hypertension, and pathology in the fellow eye was the only risk factor for intraocular pathology in mature cataract eyes. There was no role of age, gender, axial length, luminescent cataract for development of intraocular pathology in the mature cataract eyes. So the conclusion is that the most prevalent intraocular pathology was drusen, followed by glaucoma, myopic degeneration, and retinal detachment, albeit in a limited number of cases. Diabetic retinopathy was observed in a few instances along with other less common pathologies. Interestingly, while univariate analysis indicated the significance of certain factors like luminescent cataracts and medical histories, multivariate analysis pinpointed the history of diabetes, hypertension, and a fellow eye pathology as the primary risk factor for intraocular pathology in mature cataract cases. The findings suggest that these specific medical histories are strong indicators of potential ocular complications in this demographic. In summary, the study results spotlight the critical role of patient history in predicting intraocular pathology post-cataract surgery by focusing on diabetes, hypertension, and fellow eye conditions. Healthcare providers can implement and target interventions to enhance the post-operative care of mature cataract patients. These are my references.
Thank you. Please collect your certificate. And next speaker is Dr. Sophia Chaudhary. Sophia is present here. Dr. Next. Sophia is absent. Dr. Priyanka Sundar.
Good morning, everyone. I'm Dr. Priyanka. I am here to present a study of morphometric changes of cornea in case of pterygium. Introduction: pterygium is a benign growth that begins on the bulbar conjunctiva and can extend to the limbus and beyond, with a higher incidence at the nasal limbus than the temporal. Pterygium occurs more frequently in men and those between 20 and 40 years of age. The primary causative factor is believed to be exposure to UV light, particularly UVB radiations, which can lead to mutations in the P53 tumor separation gene. Pterygium-induced body astigmatism by flattening the area between the cornea, central cornea, and the advancing end of the pterygium, resulting in epithelial astigmatism. This study aims to explore the relationship between pterygium morphology and changes in the keratometry, corneal endothelial cell density, hexagonality, and the coefficient of variation in patients with pterygium in a tertiary care hospital. Criteria and methods. This study is an analytical prospective study conducted between March 2022 and March 23 in Ophthalmology Department of Sardar Patel Medical College and Associated Group of Hospitals, Bikaner. The study consisted of 100 patients with unilateral pterygium who met the inclusion and exclusion criteria and were selected through consecutive sampling. A pre-designed proforma was used to collect data, which included a comprehensive ophthalmic and clinical examination, visual acuity assessment using a logMAR chart, and corneal curvature assessment using an autorefractometer. Now, the corneal endothelial cell density, center corneal thickness, coefficient of variation, and hexagonality were evaluated using a non-contact specular microscope. The severity of pterygium was determined based on its morphology using slit-length examination, and the patient's healthy eye was considered the control. Before participating in the study, the patient provided informed written consent and received approval from the ethics committee. And the results. First table is showing the demographic data. In our study, most of the patients belong to the age group of 21 to 40 years, that is a 43%, and 42% patients belong to the 41 to 60 years of age group. With the male predominance, that is 53%, and 56% patients hail from the rural areas. Table 2 is showing the refractive and the keratometric data. In our study, the visual acuity is less in the diseased eye than the normal eye, and the mean difference of K2 and K1 was more in the diseased eye in comparison to normal eye. Table 3 is showing the morphometric data. Endothelial cell density, center corneal thickness, and hexagonality were decreased in diseased eye in comparison to the normal eye, and the coefficient of variation is more in the diseased eye than the normal eye. Discussion. Our study showed that the patients older than 40 years have the highest prevalence of pterygium, while patients aged 20 to 40 years are reported to have the highest incidence of pterygium. A statistically significant association was found between outdoor work and the pterygium formation, which may be related to high exposure to sunlight and dust in outdoor workers, which was comparable to the study performed by Zedi et al. In our study, the mean values of visual acuity were less in diseased eye than in normal eyes in all grades, but the difference was found to be significant in grade 2, 3 and 4 of pterygium. In our study, we observed that the mean difference of K2 and K1 was less in normal eyes compared to the diseased eyes. Our study found that the mean values of central corneal thickness was less in diseased eye than normal eyes in all grades of pterygium. Our study found that the density of endothelial cells was higher in normal eyes compared to eyes with pterygium across all grades of pterygium, which was similar to the study conducted by Mutra et al. Conclusion: pterygium leads to deterioration of visual performance not only by causing refractive and keratometric changes, but also by causing the significant morphometric changes. Further longitudinal studies need to be conducted on a large scale to confirm this association between these variables, as this having a serious risk for post-operative edema and decreased vision, especially among patients that requires cataract surgery. These are the references.
Thank you. What do you think is the cause for endothelial cell loss in pterygium? You said the endothelial cell count was reduced. It is a disease. Pterygium is a disease of conjunctiva. Why? What is the hypothesis? Any cause given for that?
So it grows from the conjunctiva to the cornea, crossing the limbus.
But only the epithelium is involved. Why is endothelium involved? What? It is there, okay, agree. But you have to give some hypothesis or some reason, logic for that. Do you have anything? Thank you. The next speaker is Dr. Ritu Kala.
Good morning. Hello. Good morning to the respected panelists. I'm Dr. Ritu Kala. The topic of my paper is an observational study of the anatomical and visual outcomes after silicone oil removal in cases of complex retinal detachment. Retinal detachment is the separation of RPE and neurosensory retina. In this study, What do we mean by complex retinal detachment is RD, which had proliferative vitreoretinopathy, proliferative diabetic retinopathy, history of ocular trauma, choroidal coloboma, or TRD, which was secondary to the BRVO. In exclusion criteria, we excluded the patients in which the tamponade were either gas, scleral buckling was done. In this study, all the patients were managed in the following procedures. First, we did the 23 gauge pars plana vitrectomy. Then peripheral base shaving was done with the help of PFCL, injection, BBG followed with ILM peeling, then retinotomy and subretinal fluid were drained. 360-degree retinoplexy and laser photocoagulation of the breaks was done. At the end of the study, silicone oil was inserted as in tamponade. Keeping in mind the complications of silicone oil tamponade, such as cataract, which is most common, raise in IOP, secondary glaucoma, optic atrophy, emulsification of oil, migration of oil, formation of band-shaped keratopathy, and proliferative vitreoretinopathy. It is advisable to remove the oil as soon as the retina has gained its stability. The best time for silicone oil removal is 2 to 3 months. 3 to 5 months after silicone oil removal, retinal detachment is most unlikely. The aim was to study the anatomical and the visual outcomes after SOR in eyes with complex RD. The objective was to study the retinal stability and to study the retinal detachment in terms of risk factors, timings, and primary pathology, and to study the visual outcome. This study was conducted at SMS Medical College in Jaipur, and it was an observational prospective study. All the patients who had the SOR surgery with history of complex RD were included. This study was conducted from 1st January 2023 to August 31st, 2023, and the sample size was 60 cases. 60 eyes of 60 patients were included, out of which 38 were male and 22 were female. The diagnosis was 50% of the patients had RD with PVR, 16.7 had RD with great giant retinal tear, 13.3 had RD with PVR, then 10% had TRD secondary to BRVO, and other 10 had ocular trauma. So this is the distribution between the VR and SOR surgery. So the mean time was 9.63 months, median was 6 months, standard deviation was 12 months, minimum time between the VR and SOR was 3 months, and maximum time was 68 months. Comparison of the visual acuity. Visual acuity post-operative 1 week, 3 month and 3 month were stable or improved in majority of the patients. The complication, the most common complication was cataract progression, which was in 26.66% of all the cases. Here I would like to note that only 36 patients had crystalline lens at the time of silicone oil removal. So we can say that out of patients with crystalline lens, 44% progressed to cataract. Retina was unstable, or we can say retinal detachment was present in 16.7%. Ocular hypertension was in 12%. and hypotension 3.33%. In last, we can conclude that majority of the patients had good anatomical and visual outcomes after silicone oil removal. So we should compare the advantage of silicone oil removal with its longer presence in the eye and the potential for complication after SOR surgery. Thank you.
Thank you. So I think you want to say that the risk of retinal detachment after silicone oil removal was, according to your study, 17%. Because 83% maintained, or you said that.
So it was 16%, sir.
17, 16, 17%. Which confirms to other studies.
Yes, sir. It is comparable.
There are various studies, the range of the incidence of silicone detachment after silicone oil removal varies from 10 to 15 up to 20%. Secondly, you have not shown any of your pictures actually. They are all pictures taken from network notebooks. You should have shown some of your pictures also. That would have given some weightage.
Yes.
Thank you.
Thank you, sir.
Correct your certificate. Now, Dr. Deepika.
Good afternoon. My topic for paper is complication of pseudoexploration syndrome in cataract surgery at Tertiary Care Center. Pseudoexploration syndrome is an important ocular manifestation of a systemic disease. Lindbergh first time paid attention to grayish flakes and fringes at the pupillary border and on anterior lens surface. Pseudoexfoliation is common in cataract patients and also observed in 50% of glaucoma patients as well. Pseudoexfoliation is more prevalent with advancing age. Clinically, the diagnosis is made by detecting the whitish powdery deposits along the pupillary margin or whitish grey flaky material on the anterior surface of the lens or both. This deposit also found on zonule, ciliary body, corneal endothelium, anterior vitreous, and trabecular meshwork. The important implication for patients with pseudoexfoliation syndrome is increased incidence of intra and post-operative complications when they undergo cataract surgery. Pseudoexfoliation causes serious complications during cataract surgery such as zonular dialysis, capsular rupture, and vitreous loss. Glaucoma is the most common sequelae of pseudoexfoliation syndrome. So my aim is study is to evaluate the clinical profile of eyes with pseudoexfoliation syndrome and outcome after manual small incision cataract surgery. Inclusion criteria: age more than 50 years, patients with pseudoexfoliation getting admitted for cataract surgery, consenting for manual small incision cataract surgeries, able and willing to give informed consent. Patients excluded from the study are patients with raised IOP, glaucomatous disc changes, other causes of cataract like traumatic metabolism, complicated and uncontrolled diabetes mellitus, or other systemic or cardiovascular diseases. Not consenting to manual small incision cataract surgeries, iridodensis, phacodensis, and subluxation of the lens due to any other pathology or any other allied ocular pathologies. My study is prospective study, and I used 100 patients with pseudoexfoliation who underwent small incision cataract surgery. Analysis was done by GR square test, and I used one-way ANOVA for analysis. Then study place is GNE Hospital and Medical College Jaipur. Methodology: all recruited patients underwent detailed ocular examination pre and post cataract surgeries, including visual acuity by Stenel's chart, anterior segment by slit lamp examination, anterior chamber depth by Wen-Herrick's grading, tonometry by applanation, gonioscopy by gonio lens, and posterior segment examination by IDO, pupillometry by scales, and manual small incision cataract surgery was performed by single surgeon in all the cases. Result: out of 100 patients with pseudoexfoliation who underwent manual small incision cataract surgery, 22 patients had complications like zonal dialysis alone was found in 5 eyes, that is 22.7%, and zonal dialysis with vitreous loss was seen in 5 eyes, that is 22.7%. Only posterior capsular rent, that is PCR, was found in 3 eyes, that is 13.6%, and PCR with vitreous loss was found in 5 eyes. Sphincter tear was noted in 3 eyes and iododialysis was seen in 1 eye. These are the results. Post-operative visual outcomes, near normal vision, that is more than 6 by 18, was found in 87 eyes with pseudoexfoliation. Visually impaired, that was less than 6 by 18, was in 9 eyes. And severe visual impairment, that was less than 6 by 60, was found in 4 eyes. And 0 in legal blind and social blind patients. Discussion. Complications rate in our study were similar to study done by Satish et al. In 500 eyes with pseudoexfoliation with cataract underwent small incision cataract surgery. With IOL implantation, PCR was seen in 50%, vitreous loss was seen in 40%, and iododialysis was seen in 4 patients. In study of Javed et al., most common intraop complication was vitreous loss, that is 10.5%. PCR was seen in 9% and damage to sphincter pupilla was seen in 8%. Retained lens matter was seen in 6% and zonular dialysis was seen in 4% patients. These results were consistent with the results of our study. Thus, it can be observed from various studies that manual small incision cataract surgery in pseudoexfoliation eyes has been associated with more frequent complications. So the conclusion is that all ophthalmologists should focus on early detection of pseudoexfoliation in view of risk of intraop complications related to pseudoexfoliation. The diagnosis of pseudoexfoliation may also be important in the management of cataract in these patients. My references. Thank you.
Thank you. Why do you use these terms like scientific study, like near normal vision? I don't think that is advisable, because you have to give some numeral vision from 6.6 to 6.18. That's all. Don't commit or don't say that this is near normal. That will land you in trouble. Secondly, your percentages I don't think is correct, because out of 100, how can you have 22.7% cases with some problem? Well, you had written 22.7% of risk of complication. If the number of patients was 100, how can you have the incidence as 22.7%? Either some typographic mistake or some mathematical mistake. Thank you. Thanks to all the presenters. Thanks to Dr. Chauhan. We end this session. We all proceed to all A for the oration. Thank you.